Good evening to all of you. Now, without wasting more time, I move on to the prestigious B.B. Dikshit oration. Professor Bhalchandra Babaji Dikshit was from a family of lawyers. So actually, he went into medicine in 1926. He graduated from the Grant Medical College, Mumbai. And later on, he was a professor in pharmacology in various institutes like in Kolkata, in Visakhapatnam, and then he moved on to Edinburgh and did his MRCP. His research is mainly on the molecule acetylcholine. Thereafter, in 1946, he was the principal of BJ Medical College. So he was the first principal of BJ Medical College, following which in 1956, he went on to become the director of the All India Institute of Medical Sciences. In the 2006, when the Research Society decided to start this prestigious B.B. Dikshit oration, where we have doyens from the field of medicine coming in and addressing us on various topics important in the medical field. Today we have Dr. Bala Venkat with us. To us, he is Dr. Bala. Though young, he is one of the pioneers in setting up certain things in anesthesiology, an eminent peri-operative physician, wonderful in giving regional anesthesia and nerve blocks. And you just have to listen to him to know what Bala Venkat is. So I call upon stage Dr. Ajay Tavre, the professor in forensic medicine and an administrator par excellence, a supreme administrator, and Dr. Sanyogita Naik, HOD Anesthesiology, to chair the session. I request Dr. Bala Venkat to come on stage. I will not waste any more time, and we begin with Dr. Bala Venkat. I hand over the mic to the chairperson.
Pranams to everyone. Respected chairpersons, Dean of BJ Medical College, Dr. Kale, the President of the BJ Medical College Research Society, Secretary, the Vice President, the entire office bearers, the Head Department of Anesthesia, Dr. Sanyogita Naik, my good friends who are organizing this meeting, from whom I've learned anesthesia. Both are professors now, Dr. Surekha Shinde, Dr. Pragnya. I'm deeply indebted to this institution, and I feel extremely delighted to speak in front of my own teachers who created me, who shaped me, and who are the foundation for the growth of their student. I'm really excited to see Dr. Vidya Mule Madam, Dr. Salunke Madam, Dr. Jamkar Madam, Dr. Tombre Madam, Dr. Padya Madam, Dr. Kelkar Madam, and all the madams who were there in the morning, including Dr. Kataria Madam. I feel privileged to speak in front of them, and it's a journey, it's very nostalgic. I'm deeply grateful for the entire organizing committee for giving me an opportunity to share my thoughts on a very important topic. They said eternal vigilance and safety is the topic, and I chose to speak on professional excellence, the essential ingredients, which would be a necessity for each one of us as we grow in life. How is that we graduate from being a student, a postgraduate, and to become a Padma Shri like Dr. Bavaskar? There should be something that you have to be doing very differently than others to grow in life and progress and to accomplish and leave behind a legacy. I think these are very, very crucial. So may I seek the blessings of Almighty God to shower His grace on each one of us and our family members, to show us the right path to grow and to give us the power to enrich the people around us. This is the beautiful Adi Yogi statue, which is in the Isha Yoga Center in the city where I come from, Coimbatore. Before I go into it, I would wanted to mention few statements which have made a huge impact for me in my life, written by Mahatriya Ra, a thinker from Chennai. I would want all the young minds to very keenly listen to every word of what this particular statement says. We may be born in a middle-class family, but we can scale such heights in this lifetime that we can cause an industrial revolution. We may be born to illiterate parents, but we can die as a scholar of world repute. We may have been considered a misfit during our childhood days, but we can become role models for the future generation. What we are and what we have been has no bearing on what we can be. We can be what we choose to be. I think it's such a powerful statement which each one of us have to think every day and choose the direction that we are going to take. And when you decide to become very powerful and a legend, you need to have certain qualities, and the next statement says it all. Keep asking yourself, my future comes from where my time goes. So where should my time go? For everything that you want to do, you need to have the time. In essence, we reach a point in life when time almost becomes our God. So this is something, an awakening statement, which every young mind has to think. If you invest more time onto academics, you become a pure academician. If you invest your time into research, you become a researcher of world repute. But when do you decide all this? You decide all this when you're an undergraduate and when you're a postgraduate and you take a different path. Everyone here in this hall wants to succeed in life. But then if to succeed in life, you have to have such strong core values. And what are these? Success is all about being in the process of joyfully creating a life that reflects your highest values, your deepest beliefs, and your greatest dreams. And I wanted every single young professional sitting here, irrespective of their specialty, to become extremely successful. I'm truly delighted, and I got inspired by the life of late Dr. B.B. Dixit, on whose name this oration was christened. I went through all the journey that he took, and I was deeply excited and inspired that how even in the pre-independent era, he took a different path. Born in a small village near Amravati in 1902 in Maharashtra, he scaled great heights to be a legendary figure in the field of medicine. And when he became the director of All India Institute of Medical Science, the first director of the most prestigious institution of an independent India, it was such a glorious moment for everyone from BJ Medical College, because he was the first principal and later on became the first director of All India Institute of Medical Science. And then if you read his biography, it shows that how dedicated and committed and how much he was loved as a human being. The first 2 decades of his career, he was a distinguished scientist. He was a physiologist, he was a pharmacologist. As Dr. Pragnay had mentioned, he did a lot of work on pseudocholinesterase and also worked on opioids. He also worked on pseudoephedrine. And later, when he became a teacher and an administrator, he was one of par excellent, and he was very close to his students. He also used to play, a sports person, used to play hockey with his students, and he became a part of the family of students, and students loved him the most. So he had the essential ingredients of what today's topic is, of professional excellence. He's a true role model and a person who lived a life which every slide of mine is going to depict. I bring to you greetings from Ganga Medical Center and Hospital, Coimbatore, where I work. It's a 650-bedded tertiary care referral center for trauma, orthopedics, major reconstructive microvascular surgery. We have about 38 operating theaters, and we operate about 125 surgeries every day. And whenever you are asked to deliver an oration, whenever you're given an award or an accolade, I think it belongs to several people who make what you are today. So at this juncture, I would like to immensely thank the chairman, Dr. Shanmuganathan, the managing director, Dr. Kanagavalli Shanmuganathan, my two mentors, the chairman of the plastic surgery, Dr. Raj Sabapathy, and the chairman of orthopedics, Dr. Raj Shekharan, who are absolute eminent clinicians, researchers, won several international awards, put India in the global map, and we are the only hospital in the whole Asia recognized for major spine surgeries. We go into the allied group called as the ISOC group. So they do pioneering work and they inspire us to match global requirements and think globally. It's not enough to be the best in Pune. It's not enough to be best in Maharashtra. It's not enough to be best in the country. It is important to be best globally. Each one of you have to tell yourself today that I will live a life where I will put India on the global map. That should be the strong instinct that you develop inside you. And I take this opportunity to thank all the plastic, orthopedic, and the anesthesia department. We together work to serve our patients. A little bit about our philosophy, I'll speak a bit later. But was I destined to be an anesthetist? Was it my intention to become an anesthesiologist? The actual answer is no. When I got selected through the All India quota to do diploma in anesthesia in Pune, my first choice was actually orthopedic surgery, second was general surgery, and third was DA. Do you know what changed it? This very hall. This very hall, way back in 1989, during when I was the first year resident of the anesthesia department, I actually had in mind I will learn 6 months of intubations and spinals, write the All India entrance again and take orthopedic surgery. But this hall and this research society changed my direction. My teacher, Professor Dr. Anjali Kusurkar, the guide, gave me a topic. Succinylmethonium prolongs the action is prolonged by metoclopramide, which we use for nausea, vomiting. That was my research study. I presented in this very hall, and I'm very, very happy to say that that paper got the Best Paper Award. And you know what? Once success comes in, once success comes, all of you have to taste success. Success changes your perception of life. Success changes the way you're going to give time to everything. And hence, this very hall destined me to become an anesthesiologist. And the minute I decided to be here, I took all the inputs from all my seniors. That's why I'm deeply indebted to every professor, every teacher, every CR, because as a postgraduate, CR is your God. You believe whatever the CR says. SR is your God. Whether it's elective or emergency, throughout your life you remember what your CR said and SR said. It's not your textbooks which remain inside you. It's what our residents say. I'm deeply indebted to all of them for teaching me the right and safe anesthesia. And I just wanted to quote, when I came to Pune, I knew nobody. And first time as an All India student, we were the first batch, and it's very hard to get into a place where you do not know the language, you do not know a person. But then when I entered the office of the anesthesia department, here was a mother, Philomena, who took so good care of us. And thank you so much for making our life so comfortable. And you know, the examiners are very crucial and important. The minute the exam comes and when you have an interview, your heart rate goes leaps and bounds high. And I'm very happy to say that I have my examiner here sitting in front of me. Padya Madam, thank you for giving me the pass. And I'm very happy that you thought I was fit enough to be an anesthesiologist. So I'm deeply indebted to this institution and this very hall for making me what I am today. The minute we became an anesthesiologist, I really told myself the same thing. I was provoked, and I really believe that India has to become a world power in anesthesia. This is only my goal. All of us have to have a goal, and this was my goal. And I just wanted to say a few things. I took every opportunity to make sure that you put your best efforts to push India to the global level. And I wanted all of you to do this in every single act that you do. If you are going to conduct a meeting, that should be the best meeting. If you are delivering a talk, that should be the best talk. If you are making the slides, those should be the best slides. So the word best has to be a part of your every cell and every tissue, every time you do something. And I'm very happy to say that I have so far tried to push in, and I have delivered as a faculty lectures and workshops in 5 World Congress of Anesthesia. And then I thought, now I have to take in more faculty from India into the World Congress. And I'm in 2020 World Congress. This happens once in 4 years. I was appointed as the chairman of the regional anesthesia track for the entire World Congress. And also I became the core scientific committee member of the World Congress of Anesthesia. And I got into the dragnet 15 anesthesiologists from India to present in the World Forum. And also, I firmly believe India has got the potential to be the knowledge power of the world. And it's not just US, Canada, Australia. I think we have more power because more clinical work and lot of skill here. So we need to push ourselves. And I'm very happy to say from 2014, our institution became a learning center for Africa and Asia Pacific region through the World Federation. We train 4 anesthesiologists in regional anesthesia every year. And so far we have trained about 22 anesthesiologists from 18 countries of Southeast Asia and Africa. So every possible occasion, you need to push in this nation to the forefront. And I currently serve as the president of the Asian Oceanic Society of Regional Anesthesia and Pain Medicine, a conglomerate of 33 countries. Here again, I pushed India forward in making a lot of fellowships available for countries like Philippines, Indonesia, who need help. So my request to all of you is, you may have a humble beginning, but you need to grow very far, and you should put nation first. And I'm deeply indebted to my parents-in-law, and my family, my wife and 2 daughters, for being of great support, because most of the time we have very busy clinical work. We start our list at about 5:30 in the morning, and we finish about 8 in the night. And most of the weekends goes traveling and delivering lectures. So the family took the shock absorb of all that happened and allowed me to grow. Each one of us, the minute we were bestowed to be a doctor, you are moving into a different arena. I'm sure I wanted to emphasize this. The minute you become a doctor, you have the power to prevent a death. Creating life, very difficult by us. But preventing a death is possible by each one of us. So preventing a death is equal to creating a life. That's why every patient thinks we are next to God. And we need to grossly introspect, is this true? Am I doing things which is akin to the faith that the patient has reposed on me? So we are such a sacred branch, and we need to have very strong work ethics. When I say this, it's very important. You need to be highly focused. I think one of the biggest challenges of modern ethics is your mobile phone. Every minute after you see a patient, you want to see the mobile phone. A mobile phone has become the huge culprit of modern medicine. And I think this is a strong ethics that I would want to each one of you to inculcate, because you are next to God and you need to behave differently. And as Sir said in the previous talk, every patient expects you to listen carefully to the symptoms. And based on every symptom, you need to account. Instead of asking for investigations first, you need to come to your provisional diagnosis, and it becomes extremely crucial for you to become a clinician to listen to the symptoms, and every symptom is like mathematics, 1 + 1 + 1, and you move towards a diagnosis, and then you build a plan for management. So this should be an inherent component which will make the diagnosis easy, you become brilliant, and the whole process becoming safe, and you start the right medications. Now, the next question is, when a patient enters the hospital with a simple problem, do you think this place is a safe haven? You will be bewildered to see many of the patients who have minimal symptoms die inside this hospital because of one of the most important things, the hospital-acquired infection. And each one of us are responsible in preventing this. And I will narrate a few points for this. Hand hygiene, before and after touching the patient. The single most important factor of the death of a patient inside the hospital for a problem which he has not come for is hospital-acquired infection. And the single most important thing which will prevent this is hand hygiene. I wanted to emphasize this point. Nothing below elbow and hand hygiene are the two simple things that each one of you as a doctor has to do in preventing this hospital-like infection. Safe injection practices, prevention of surgical site infection, prevention of intravascular catheter-related infection. These are very, very important. And all this credit goes to Oliver Wendell Holmes, who said in 1843, way back, centuries ago, that cleaning the hand is important. Now, I want to ask a question to each one of you. Do we religiously do this before touching the patient and after you touch the patient? If not, this is the day to change. And I just wanted you to do this. Believe me, I'm also the chairman of the Hospital Infection Control Committee. We keep on telling this, but do you know the compliance rate of doctors? 30%. Only 30% do this, and I just wanted to emphasize the young minds that hand hygiene will prevent a death. So this is very crucial and important, and it's very, very important that you should, when you wash it, has to be diligent, and you should know that the subungual areas have the highest bacterial concentration, and you need to clean this area. These are the areas frequently missed, which I wanted to focus when you do the hand hygiene, and this hand hygiene has to be done. Moments of hand hygiene should become a poster in all your wards. And when the CR tells, the SR follows. So please, all the CRs, put this in your ward to make sure that the movements of hand hygiene is followed. And steps of hand washing should be a part of every ward in BJ Medical College. And I'm sure that next time when I come for the next Research Society meeting, I would like to see this poster posted everywhere to prevent any kind of hospital-acquired infection. Sharing syringes is something which is, I'm sure, is not done, but it's been found to be one of the important reasons in many developing nations. And unsafe injection practices, needle will be changed, but syringe will be used, has resulted in transmission of infection in several developing nations. 70% alcohol is very, very important when you do multi-dose vials. When you take an injection from a multi-dose vial, make sure that you clean the top portion of the vial with alcohol to make sure that you take away all the organisms that are present here. This is something very, very important. Antibiotic stewardship. I want every one of you who prescribe antibiotics to know about this antimicrobial stewardship and prophylaxis, because this seems to be the next important challenge. Multi-drug resistant organism emerging because of our practices. Just like that, we start antibiotics without taking into account why you started it, and it keeps going without knowing why you gave it. So this is the second focus of antibiotic stewardship and preventing multi-drug resistant. This I consider as the single most important point which we decrease the surgical site infection in our hospital. All major spine surgeries and joint replacements, they are given a chlorhexidine bath the day prior to surgery and the day of surgery. So when your parent or your son, your children undergo a surgery, make it a point that they have a chlorhexidine bath before they go to the operating theater. The chances of a surgical site infection seems to be extremely less. And all the CRs have to teach the JR how to wear a glove properly. This, you think it's very simple, but we did an audit and we saw even senior doctors not wearing the gloves in the appropriate way. These are small things that you will do to make sure the patient who believed in you and who came in you, you don't result in a murder of him by using practices which are not supposed to be done. And in a nutshell, hand hygiene, antibiotic stewardship, appropriate antimicrobial prophylaxis, strict asepsis while placing lines, removal of indwelling catheters, especially urinary catheter. Single most important cause of urosepsis in women in this country to die in the postoperative period is just leaving off the urinary catheter for a long time. Remove it the minute you think it's, or every time you do a ward round, ask yourself, is this catheter has to be there? Is it going to solve a purpose? If not, please remove it. You're going to save a life. And I spoke about chlorhexidine bath. In the process of looking after your patient, it also becomes extremely important that you protect yourself. I've seen many people don't wear the gloves in doing the venous cannulations. I just wanted to let you know that your life is so precious and important, and you need to have the personal protective equipment. The second most important thing is medication error. Do you know, in the most developed nation, United States, every day there is a death because of medication error. Do you know that last year, 7 million patients in the US are impacted by medication error, and it takes over 1% of global health expenditure. Last year, 237 million plus medication error happened in UK, where they have registry. Think about our nation. We don't have a registry, so we do not know what it happens. The problem happened in the prescription, in the dispersion, and the consumption. I just wanted to urge, when you prescribe very legibly, exact dose, and see if there is going to be idiosyncrasy with the pre-existing drugs the patient is taking. The next important thing where you can be of great help to your patient is blood transfusion. I would wanted all of you who are working in the ward who transfuse blood, please read the guidelines of WHO on safe blood transfusion. And a blood once taken out of the blood bank is best to be given within 1 hour, because after that, all the RBCs lies, and the very purpose of your giving blood and the oxygen carrying capacity is gone. So please read the right prescription for a blood transfusion. I chose this to add because India has become the global leader in having the maximum road traffic accident in this world. We are in the red. And every 3 minutes there is a death in India due to road traffic accident, and you have the power to prevent the death. And this is something which we see day in and day out in our hospital. And I just wanted to take a minute to show the philosophy. When a patient comes like this injured, run over by a vehicle, an ambulance comes and leaves in the hospital, the philosophy for the past 3 decades of our institution: do not ask money, do not ask for a blood donor, do not ask for a signature, just go ahead and treat this patient. Just send a police intimation, go ahead and treat this patient. So this patient was run over by a vehicle, by a lorry, and came gasping. And I'm also happy to say that the last 20 years, anesthesiologist took over as perioperative physician and the leader of trauma care. We do the E-fast, we do the lines, we do the entire resuscitation, we do on-arrival blocks to make them pain-free. So this patient needed 24 units of Paxil and 24 units of fresh frozen plasma and platelets, but believe me, he survived, and his relatives came much, much later. If he had not done it, they would have gone to the mortuary rather than to the ICU to see a living patient. So each one of you here have got a power to prevent a death and make sure that a family is not deprived of a father, a mother, a son, or a daughter. We are so important, and we need to do our responsibility with a lot of commitment to our patients. So just see this patient with such a significant injury, but we do an ultrasound-guided block the minute the patient comes in and make him pain-free the next minute. You see such a comfortable patient. So now, each one of you here, it's my earnest desire that you become a power to reckon. I want you to become iconic in your chosen field. I'm sure your parents have put in so much faith in you and have sent you to the medical school thinking that you will be an icon, and I really want each one of you to be iconic. How to become a power to reckon and iconic? I will have few steps, and I know that the weather is not very conducive to listen, so I will go through these steps which I consider very crucial for you to grow. complete belief in self. Number one, absolute self-discipline on what you decide to do. Think positive. Every morning, the most successful people attribute their success to the first 1 hour of the morning. You have to do little physical exercise, yoga, listen to divine music and positive book. A book like which I was really benefited is Unposted Letter and Most and More. Both are available in Amazon. 1 page of that, your day changes. So I would really urge the young minds to think extremely positive and begin the day. The ability to subordinate an impulse to a value is the essence of a proactive person. Such an important statement. When you decide to get up at 5 in the morning to read, this is the value. But there is an impulse that says, no, sleep for some more time. And then you go to bed again. But then those who succeed are those who subordinate an impulse to a value. I just wanted you to think this is such an important thing. And every successful individual as a professional to take the right decision the next day has to have 6 hours of good sleep the previous day. They become the most successful people in the world. So sleep away to success is something very, very crucial that you need to know. And you need to learn to beat the alarm. As I said, the first 1 hour is most crucial for every successful person, and do start early to work. If you need to report at 8 o'clock, it's the best thing to be there at 7:50 so that you're all set and there is no palpitation of going late and facing your teacher and getting the scolding. Start early and you plan the day beautifully, and time management results in your success. And few steps, 7 steps for you to become the best. Number 1, phenomenal confidence inside you. 2nd, passion to your profession. 3rd, mastery plus passion results in respect that you earn. 4, ability to learn to communicate very well. 5, take additional responsibilities which were not expected from you. 6, transfer the legacy to your juniors. And 7 is to enrich your inner self phenomenally. How do you become confident? You become confident by reading a lot and becoming extremely knowledgeable. And this knowledge you have to start implementing, and you have to become extremely skillful. Keep on doing the procedures, intravenous access, bladder catheterization, whatever. Keep on doing, and be the most skillful person. When skill and knowledge adds, you are respected by everybody. The minute you come, they all know, oh, this doctor is here. Even the nurse will know, oh, he will start the IV line well. He will do a good job. So skill and knowledge results in a lot of respect. And it's very important that this is a research society meeting, and each one of you should embark on doing a clinical audit, a research in your chosen field, and you need to go and adopt evidence-based best practices, and believe me, you will become a world leader for sure if you keep doing it. And you should have the mastery at work, and good judgment results in very good clinical outcome. And who is the best judge of your growth? You yourself. And you need to exceed your expectations. And how do you do that? When you need to exceed your expectations, you should have the combination of good skill, excellent knowledge, integrity to the institution, and humility to the core. This will push you to be the best in your chosen field. And this is a lovely statement. Masters make everything look so simple. The most brilliant of the best do their craft with effortless ease and exceptional grace, or at least make it look that way to you and me. And excellence is never an accident. And repeated practices will make you excellent. So once you become confident by your skill and knowledge, next is you have to perform your profession with tremendous passion. And I quote Wright brothers always, who invented the aircraft. When multiple institutions in US were trying to promote aircrafts, these are the two brothers sitting in a village were the first one to create the aircraft. So each one of you have to evolve and have tremendous passion to what you do, and drive away the lethargy and boredom that you have, and take the first step. In India, even a question is asked, we all keep quiet. And when somebody says, please raise the hand, you see the entire hall. If others are raising the hand, you also raise the hand. But don't be like that. So take the first step and every day ask yourself a question. What have I done yesterday to learn more? And how do I go to the next level of greatness on every passing day? So mastery plus passion is respect earned. And then the brilliant of the best have the ability to communicate well. You may be the best clinician, but how the world knows that you are the best. So you need to communicate to your patients very well. You should be very assuring with your colleagues, with the administrators, assuring quality, with the industry leaders, and assuring growth and safety and innovating new products. And you need to be a part of the society you belong to and present a lot of presentations in the state level and in the national level and then the international level. And you need to become a leader by yourself, by taking more responsibility. You need to become the part of the committees which work on safety, like blood transfusion committee, infection control committee, pharmacological committee. Believe me, if you go into this, you will understand the lacunae that are present here. And please make this a component of you in whichever specialty you are. Money is not everything. Don't ask your a question that if I do this, what I'm gaining, how much money I'm gaining. Please remember that we are next to God and money is not everything. And you need to contribute phenomenally to your specialty by clinical audit, research, record keeping, and data. And share this experience to the world. Keep on updating by reading the journals, visit centers of excellence, and be a part of international meetings. And once you have become a giant in your field, please pass on every bit of that to your juniors, and you create a legacy for yourself and go for shared leadership. And the last one is a strong person enriches his inner self. You become an epitome of calmness inside, but powerful outside. And you do this by having to be very happy always, to have an inner peace. You need to manage your time and balance your activities. And most importantly, you should have an excellent family life and a very happy home, which will propel you to great heights. And this is the weekly planning of the most successful people. 1 hour for physical wellness, 1 hour for reading and contemplation, 1 hour with family for emotional support, 1 hour for futuristic growth, and 1 hour for spiritual needs. If you devise your day, you are going to become a legend in your field. And before I conclude, I just wanted to say the top 9 qualities of each one of you to push you to the pinnacle. Number 1, the art of communication. Number 2, being an extremely positive person. Number 3, you need to inspire people around you. Number 4, commitment to the cause. Number 5, as you grow, learn to delegate and get the work done. Work with intuition. Don't go by what the world thinks. You need to get in a new world order. Then confidence, honesty, and creativity. If this becomes a part of you, you will be speaking, you will be a part of international fora, and you will make India proud. And I wanted several people here to be the change that the modern India wants to do. And I'm very confident that all those who are here will apply their mind, not only about their education, about what they're doing for their institution. You need to put the country first. And this next decades should belong to this vibrant nation. And you and I have to be a part of an India which becomes a global leader in medicine, and this day is not far away. The happiest people don't have the best of everything. They just make the best of everything. And I'm sure we will all do this together. This is a very nice statement of Jim Collins. Leaders display a paradoxical combination of personal humility and professional will, channeling their energy, drive, creativity, and discipline into something larger and more enduring than themselves. And I wanted each one of you to think big. And the last slide. Treat every patient as your own kith and kin. And no medication errors will happen. No hospital-acquired infection will happen, and patient will not die because of negligence. And each one of us should be a part of this journey of making sure that every patient comes to us lives, and since we have the power to prevent the death. By doing so, you do proud to yourself, to your parents, to your institution, and to your nation. And we have to rise like a phoenix. It's not enough if our sports people win awards in the Olympics. We need to do something to our specialty to put it at the global level. And I'm extremely confident that each one of us will allocate time, create opportunities, and make this happen. And I sincerely thank for giving me this opportunity to speak on professional excellence, the essential ingredients. And I'm really, really happy to have presented this to my alma mater, to the same hall where I sat in the last row and presented my research society paper. And today, I consider it as a deep honor to be present in front of my teachers, my examiners, and my CRs, and SRs, and JRs to deliver this talk. I'm deeply indebted to each one of them for making me what little I've been able to accomplish. Sincere thanks for the opportunity. Thank you very much, and I'm very happy to be a part of it.
I now request our chairpersons, Dr. Sayogita Naik Madam and Dr. Ajay Tavre Sir, to kindly felicitate Dr. Bal Venkat Subramanian Sir.
Thank you very much, sir. And we are very proud of you, as you are an ex-student of this institute. And all anesthetists, national and international faculties are proud of you, especially our student for your teaching approach. Thank you, sir.
I request Dr. Pratnya Bhalerao Madam to felicitate our chairperson, Dr. Ajay Tavre Sir. I request Dr. Sushma Tandre Madam to felicitate our chairperson, Dr. Sayogita Naik Madam. Good morning, respected dignitaries, faculty members, and my dear colleagues. Moving on with our program, we all are aware of the recent incident that took place in the Dausa district of Rajasthan, where a young medical practitioner was booked for the murder of one of her patients, a pregnant woman, as a result of complications. The doctor then committed suicide as she succumbed to the pressure of proving her innocence. We all are also aware of the many incidents of doctors being assaulted and beaten up in wards and hospitals. The rising number of such incidents instills doubt and fear in our minds and may eventually compromise on our patient care. Therefore, today we have a panel discussion with our team, Dr. Rajiv Joshi, Dr. Jayant Navrange, and Dr. Pratibha Kane, to guide us on how to practice without fear. I now request our chairpersons for the session, Dr. Naresh Jhanjad, Professor and Head, Department of Forensic Medicine and Toxicology, Dr. Sanjay Gaikwad, Professor and Head, Department of Pulmonary Medicine, and Dr. Harish Tatya, Assistant Professor, Department of Forensic Medicine and Toxicology, to come up on stage and introduce our speakers. I request our chairpersons to kindly introduce the speakers.
Good afternoon all. Hello. Good afternoon all. So this session is the panel discussion. This regarding to practice without fear, how to manage the growing threat of violence and criminal negligence against doctors. And as a panelist, we have two eminent panelists with us and a moderator, Dr. Kane Madam. So the first panelist is Dr. Raju Zoshisar. He did his LLB. Also, he is a MD Pediatrics. And in the training in medical informatics. Then he had many awards with his name. That is certificate in HLZ fundamentals in 2013. Best game changing the idea awards in 2011, that is awarded by Telemedicine Society of India. Fellowship in biomedical informatics in 2008. Then observer in medical genetics in 1991. Then he had also many awards. Recently he filed a PIL. Probably the sir will explain regarding that PIL in detail. So I welcome Dr. Joshi sir for this panel discussion. The second panelist.
Good afternoon, everyone. Our second panelist is Dr. Jayant Navrange sir. He is a gold medal in MBBS and has completed his MD in pediatrics. He was also fourth in LLB. He is providing his honorary pediatric services in Srivatsa Sassoon General Hospitals, as well as Bharatiya Samaj Seva Kendra, Dina Hospital and Sahyadri Hospitals. He has been also the past president of IMA Pune, IIP Pune and IIP Maharashtra. He is also vice chairman of medico legal cell of IMA headquarters. He has helped around 2,340 doctors so far in fighting medico legal cases. He has also designed and conducted the first medico legal course for Indian Medical Association. He is also visiting faculty at ILS Law College, Pune. You can see he has also completed 26 half and full marathons and is fond of cycling. He has donated blood 65 times. He is also recipient of Bertha Holt International Award for rehab of 10,000 family-deprived children in last 40 years in USA 2002. He is recipient of Best Indian Doctor Award by Indian Medical Association 2015. This award was installed in 2015 only. He is also Chairman IMA MS Social Security Scheme from 2018 to 2023. Welcome, sir, and thank you for this.
Good afternoon, all. Let me introduce today's panel discussion moderator, Dr. Pratibha Kane Madam. She's MD Anesthesia, LLB, MPM, HOD Anesthesiology, Jahangir Hospital, Pune. Her 30 years experience in Jahangir. Executive Committee member of Society of Anesthesiology, Pune. Past President, Pune City. Postgraduate teacher, DNB Anesthesiology since June 1997. LLB with honors, certificate from Oxford, UK for healthcare communication. Gold medal for MD Anesthesiology. Presentations at state and national conference on medico-legal topics. So, yes, welcome, madam. I think we can start your moderation.
Good afternoon. I know it's a little late, and with the permission of the chair, I would like to start. I thank the organizers for giving all of us this opportunity to present a topic which is very close to our hearts, that is to practice without fear. This is a panel discussion of implementable solutions to manage the growing threat of violence and charges of criminal negligence against doctors. And our objective is to find solutions to allow clinicians to do to be free to save lives in good faith without any fear of adverse consequences in case of poor outcome. And let there not be another Archana Sharma. So violence is any physical is application of any physical force used to injure healthcare personnel and damage or destroy hospital property. It also means the use of abusive language, confrontation, threats, intimidation, escalation to physical abuse, kidnapping. In 2012, in Tuticorin, Tamil Nadu, the husband of a deceased patient came to Dr. Sethu Lakshmi's residence and murdered her. There are some trigger factors which provoke violence, and all of us must be aware of this. These are arrogance, rudeness, disrespect, senior doctors not engaging with the patient or relatives, no explanations given for poor outcome, delay in treatment or transfer, death during transfer, and billing issues. Financial counseling has become extremely important from day one, and not releasing the body for payment of bills is something that always triggers violence. So, our care must be patient-centered. We must have a compassionate attitude, and we must show empathy. We must give prompt attention to sicker patients, a high standard of pre or perioperative pre-procedure care. Counseling of patients is extremely important for them to understand the risks and benefits of any procedure. Give realistic expectations, no false assurance by any doctor or any member of the team. If required, it is better to shift early and shift with a doctor. Breaking bad news is always a sparking point. A senior doctor must be there to explain and answer questions. They must repeat things to improve understanding, must use a low tone of voice, a slow pace, and no jargon. There are certain precautions to be taken while conveying bad news. So you can have a room with 2 doors and no free objects. Never do it alone. Always call a colleague or a senior. And the rule of 2 + 2 is very good. Only 2 relatives and preferably 2 doctors. So you must inform the security in advance and do not argue or raise your voice. If you feel that the safety is in danger, it is better to leave the premises. Now, there are certain special categories of patients which Dr. Naurange is going to tell us about. So please, the category of patients where we have to be a little extra precautious.
At the outset, I thank the organizers for calling us back to the alma mater. We are all studied over here, and we are the past students of this same very college, and we are on the dais intermittently, at least I suppose once a year. Respected chairpersons, this is the thing which we have come out of the practical importance. What are the categories of patients where we are going to give the same type of treatment, same type of attention, same type of management to every patient with that particular disease, isn't it? आपल्याला भिकाऱ्याचं मूल असू दे नाही तर पंतप्रधानाचं असू दे, ट्रीटमेंटमध्ये फरक होता कामा नये, विच इज अ करेक्ट प्रिन्सिपल. बट देन देर आर सर्टन, एक हाताने टाळी वाजत नाही. आपण जे बघितलं मगाशी मॅडमनी सांगितलं की what could be the arrogance of the doctors, poor communication. This is one category. Everybody is there to teach the doctors. Everybody is there to teach the doctors. तुम्ही असं केलं पाहिजे, तुम्ही तसं केलं पाहिजे. At the same time, there are special categories of patients where you have to be a little extra careful. In the sense, we continue the treatment, but this is 5 P's and 1 N, or 6 P's and 1 N. So there you have to be a bit more extra careful medico-legally. And these are these category. Press people as patients. Press means media people. पराचा कावळा करण्यात हे लोक एक्सपर्ट आहेत. कुठल्या अँगलनी बघायचं हे त्यांच्यामध्ये अवलंबून असतं. सो हिअर इज वन थिंग, प्रेस वी व्हेरी कॉशियस अबाउट व्हॉट वी आर टेलिंग. नंबर 2 आर द पोलीस पीपल. वेन दे कम ॲज पेशंट्स ऑर दे रिलेटिव्स कम ॲज पेशंट्स, कारण त्यांना असं वाटतं की दे आर प्रिव्हिलेज पीपल अँड दे वॉन्ट एक्स्ट्रा केअर, आउट ऑफ टर्न. आपण मगाशी सरांनी सांगितलेलं बघितलं की मॅडमनी सांगितलं की गिव्ह मोर आय मीन pick them up early. More sick patients, you should call them earlier, even if they are not in the queue. So here they feel that every symptom of them, even if it is common cold, would be taken up by a preference. Thirdly, these politically influential patients. So here also we require their help in certain situations, but then we have to be extra careful when we are dealing with them. Pleaders as patient, pleaders म्हणजे lawyers. त्यांना एक असं वाटतं की आम्ही हॉस्पिटलमध्ये गेलो की बरं झालंच पाहिजे. 95 वर्षाची म्हातारी आली, तिचं डेथ झालं आणि रुबिऑलच्या सिनियर KB ग्रँडला धक्काबुक्की झालेली आहे. सो दिस हॅपन्स. तेव्हा असं काही पेशंट इज पेशंट, जीव हा जीव आहे, ह्युमन इज ह्युमन. सो दे कॅनॉट क्लेम, बट दिस इज व्हॉट इज हॅपनिंग. फिजिशियन्स ॲज पेशंट्स, त्यांच्यापुढे आपण काय बोलतोय, बी व्हेरी केअरफुल अबाउट युअर ओन कलिग्स. पर्टिक्युलरली आय वुड से द अदर वे राउंड. वेन वी आर टॉकिंग अबाउट द आउटकम ऑर सम ट्रीटमेंट आउटकम ऑफ अ person, we should honor the previous doctor rather than criticizing the doctor. That is what I am saying. That backbiting or medical jousting is one of the things which drags the patient into litigations. Another category which has come off late in last 5 years is the poor patients. This, I am not talking from Sassoon point of view. I am talking about from corporate or private patients point of view. That poor patients with yellow and saffron cards. म्हणजे थोडक्यात म्हणजे काय, येलो कार्ड त्यांच्याकडे रेशन कार्ड आहे किंवा केशरी कार्ड आहे. त्यांना तर असं झालं की त्यांचं सगळं दैवदत्त हक्कच आहे, सगळी ट्रीटमेंट फ्री मिळायचं आणि 100% जीव वाचला पाहिजे. तेव्हा दीज आर द क्लास ऑफ पीपल विच गिव्ह द मॅक्सिमम ट्रबल टू द प्रायव्हेट सेटअप. सो पुअर पेशंट्स अनदर P with yellow and saffron cards, very very dangerous category, particularly in the last 3 to 4 years. आणि याच्यात गंमत मी तुम्हाला सांगतो, अनफॉर्च्युनेट आहे. कॅन यू चॅलेंज दिस येलो कार्ड? तो येतो इम्पाला गाडीतनं आणि येलो कार्ड दाखवतो शेवटच्या क्षणी. दिस वी हॅव सीन टाइम अँड अगेन.
Yes.
In all hospitals. So initially our hospitals did challenge this, saying that your income is definitely more than this and you cannot fit into the yellow card. Then the charity commissioner, his ego was hurt, and they have taken out a government circular, GR, saying that there is no authority with the doctors in hospitals that they can even suspect or challenge these yellow cards, and once they have issued it, given. आजचा रेट त्याचा 7,000 रुपये आहे सर. 7,000 rupees you pay and you can, even I can get a yellow card. I can assure you. This is the unfortunate situation. NRI and their relatives at patient. हे NRIs लोक असतात ना, आपल्यातलेच काही लोक तिकडे गेलेले, साता समुद्र पुलेकडे जाऊन बसलेत. त्यांना असं वाटतं की त्यांच्याकडे डेथच होत नाही. ICU मध्ये काही डेथ होत नाही का? 26 to 36% is the overall world mortality for genuine ICU admissions. तर त्या ठिकाणी त्यांनी तिकडून सांगायचं की असं इकडे माणसाची माथी भडकतात. दे आर नॉट ॲक्च्युअल द कल्प्रिट्स, बट दे आर इन्स्टिगेटिंग द फ्युएल, आय मीन इन्स्टिगेटिंग द फायर बाय पुटिंग इन मोर फ्युएल. आणि ह्यांच्यामध्ये कॉम्पेन्सेशन ते मागताना काही कुठे हायेस्ट कॉम्पेन्सेशन इन दिस लँड इन गव्हर्नमेंट अंडर इंडिया इज 13 crores 13 lakhs, and that is sanctioned for an NRI who is enjoying in India. त्या पैशावरती त्यांचं मजा चालली आणि डॉक्टर्सना लाथाडा घालणं आजही चालू आहे. आय थिंक यू विल ॲग्री विथ मी. सो दिस इज द कॅटेगरी ऑफ पेशंट्स हिअर. यू टू बी एक्स्ट्रा केअरफुल. यांचं डॉक्युमेंटेशन जास्त चांगलं करा. यांचं डॉक्युमेंटेशन जास्त चांगलं. आय नो विथ दिस रश वी आर फेसिंग, इट इज इझियर सेट दॅन डन. दॅट मेंटेन गुड रेकॉर्ड्स. Then it requires a paraphernalia. Then the cost goes up. But then, at least in these category of patients, have the best possible records. Thank you.
Sir, one more question for you is that in spite of taking all precautions, doctors do face this violence. So what do you think we should do when threats from aggrieved patients or irate relatives?
I think this is a burning problem, and this is not only restricted to the private sector, it is in the government hospitals also. Because most violence cases about the housemen, registrars or senior and junior residents has occurred in the OPDs or emergency rooms of the major government hospitals. What happened in Dhulia about 4 years back, the doctor lost his eyesight. So this happens even in the government. Paisha's ite prashna nahi. There is no question of billing, overbilling, etc. But even then, the expectations are so high, and that is because of aggressive consumerism and also wrong internet information. So whatever you are getting on information on the channels is information and not knowledge. So that board should be there in every OPD, every intensive care unit, every particular clinic or daycare center or hospital, that information is not equivalent to knowledge and knowledge is not equivalent to experience. And these three things together, information, knowledge and experience, makes the wisdom for a doctor. So that it should be imbibed. I would say important things in spite of that, aggrieved patients, one would be to put in CCTV cameras. Number two, follow the ethical principles what the previous two orators have given. Excellent speeches, what we learned in the morning hours, some time back. And we try to imbibe that, but that is not full, that is not adequate, because it depends on the other side also. So what we can do? Polite language, good communication, CCTV cameras, shifting in time, whatever you mentioned in the last slide. In small nursing home, follow the same. Continue to have updated records, somebody to help you. In institutions like Sassoon, I would say there should be something like a code blue, code violet, whatever you call. There should be a ring. So whenever there is a suspected violence expected to be there,
we have a code violet.
Yeah. Put it and let 300 residents come down to rescue of that situation. What happened in Dhule? There were 200 residents and interns. Why they did not come? ज्या वेळेला आपल्या विरुद्ध हातात कायदा घेतला गेतो त्यावेळेला तुम्हाला सेल्फ डिफेन्सचा फुल हक्क आहे. तुम्ही सुद्धा तुमची तब्येत कमवा. माझं वाटतं मागच्या दोन्ही स्पीकर्सनी सांगितलं रोज एक तास एक्सरसाइज करा. यूज इट. काय त्यांनी आपल्या पोलीस डिपार्टमेंटचं वाक्य आहे की त्याच्यामध्ये काय टिट फॉर टॅट इन शॉर्ट ऑफ, की ज्या ठिकाणी तुम्हाला तुमचं संरक्षण करायचं आवश्यक आहे करता आलं पाहिजे. अँड हू कॅन बी युअर बेस्ट कलिग, हू कॅन बी युअर बेस्ट डिफेंडर, हे सगळं नंतर आहे. पेपर, डॉक्युमेंट्स, अमुक तमुक, त्या क्षणाला तुम्हाला मदतीला तुमचेच कलिग आले पाहिजेत. आणि त्यांनी मागे बसून टवाळ करताना किंवा त्याला मारलं जात आहे, तुमचं पण रक्त खवळ. सॉरी.
So like Sir says that we need to all descend to help anybody who is in need. It does not happen if it is a neighborhood small clinic or institution where the code violet has been alarmed. So we have that at the code violet, there is a alarm which says code violet, code violet. At least 20 people will descend to that floor.
So what should be done in a private setup? There should be WhatsApp groups, and we have made them according to postal pin code number. पुणे 30 म्हटलं की 250 डॉक्टर्सचे 20 ग्रुप केलेले आहेत. त्या सगळ्यांवरती फ्लॅश झाली पाहिजे न्यूज. आय एम इन ट्रबल. At least 20 doctors reaching over there, and it has averted. In Pune is a role model that at least I can say that after, of course, this has been learned only after experience, that after 3 to 5 consecutive violence cases, particularly in Kondwa area, Hadapsar area, and one in, I suppose, Pimpri Saudagar, त्यानंतर मात्र हे WhatsApp group have been extremely effective, so that once there is an alarm or flash of news on the WhatsApp, 20 doctors reaching the site, it makes a real difference. आणि दुसरी गोष्ट आत्ताच सांगून टाकतो, reach the topmost police officer. There is no point in going to the local chowki. There is no point going to the local chowki, but that will come after.
Yeah. Okay. So what should we do if we have adverse media coverage, like our name is flashed in the papers the next day? What should we do?
ओके, अबाउट मीडिया कव्हरेज, आपल्याकडे लोकशाही आहे, त्यामुळे एक लोकशाहीचा चौथा आधारस्तंभ ज्याला म्हणतो तो मीडिया आहे, त्याच्यावरती बंदी घालणं अजून आम्हाला जमलेलं नाही. व्हॉट वी शुड बी डुईंग इफ इट इज अन ॲडव्हर्स मीडिया पब्लिसिटी, डॅमेज इज ऑलरेडी डन. डॅमेज इज ऑलरेडी डन. पेपरमध्ये छापून आलं की डॅमेज इज ऑलरेडी डन. आयदर यू निग्लेक्ट, युजली तुमच्या प्रॅक्टिसवर काही परिणाम होत नाही, थोडीशी वाढते. नंबर 2 गोष्ट, वी कॅन टेक द हेल्प ऑफ द असोसिएशन्स अँड राईट टू द प्रेस काउन्सिल ऑफ इंडिया. आपली जशी मेडिकल काउन्सिल ऑफ इंडिया आपल्याविरुद्ध लोक पेशंट्स तक्रार करतात, वी शुड कंप्लेन टू द प्रेस काउन्सिल ऑफ इंडिया, अँड इफ द असोसिएशन फॉलोज इट देर इज सम रिस्पॉन्स. सो मीडिया शुड बी मेड रिस्पॉन्सिबल. पण आत्ता तरी आम्ही त्यांच्यापुढे हात टेकलेले, ही सत्यस्थिती आहे. परंतु वेन इट कम्स टू सोशल मीडिया, फेसबुक आहे, so many other social media platforms are there, then they have offices in Delhi and we write a strong protest letter. परंतु फेसबुकवर आलेलं आहे, व्हॉट्सअपवरती आलेलं आहे, ॲडव्हर्स पब्लिसिटी आपल्याला झालेली आहे, हे कळायला आपल्याला 2-4 तास जातात. तोपर्यंत आपल्या सुहृदांचा इंग्लंड अमेरिकेतनं फोन येतो, अरे तुझ्याबद्दल काय लिहिलं आहे. सो डॅमेज इज ऑलरेडी डन ऑन अ वाईड स्केल. But then we write a strong protest letter. We also threaten it with a legal notice, and they have always put it down. They have pulled down that particular adverse comment.
Okay, so some
तेवढं मात्र करता आलेलं आहे.
Yeah, so some social media we can control. Next, is there any role of protests or keeping tools down? Dr. Naurange, sir, please.
I think they have very limited effectivity. First and foremost, you cannot go on strike. It comes under MESMA. We cannot go on strike. So what you can say, mass leave घेतली आपण 1 दिवस, त्याचा 1 दिवस परिणाम होतो. आपण लोकांना, कलेक्टर्सना वगैरे, वी कॅन सबमिट द आवर मेमोरंडम, आणि असं परत होता कामा नये वगैरे. पोलीस कमिशनरला पण जाऊन भेटू शकतो, हे सगळं ठीक आहे. वन न्यू नॉवेल आयडिया हॅज बीन पुट फॉरवर्ड लास्ट वीक बाय वन ऑफ द members of the medical association, and he has mentioned that select one day in a month. It can be first Monday, it can be any convenient date, something like 10th, and that particular divshi even emergencies work. See, काय होतं, इमर्जन्सी वर्क तुम्हाला चालू ठेवायला लागतं. या ग्रॅप खाली लोक सर्दी खोकला पण ट्रीट करतात, सो तो संपाचा काही उपयोग होत नाही. सो वी शुड से इवन इमर्जन्सी वर्क विल गो टू द गव्हर्नमेंट इन्स्टिट्यूट्स. 1 दिवस वी शुड रिस्ट्रिक्ट अवर वर्क. Every 10th, and every 10th on that particular day, we will be submitting it to the collector, police commissioner, everywhere. Till the time what Dr. Raju has formulated changes in the current Anti-Violence Act, they are really have been sanctioned by the Bombay High Court, and then they come as a reality, as a changed law. Till then we should follow it, pursue it. 3 महिने 6 महिने पर्स्यू करायला लागेल. एकदा करून 1 दिवस करून काही उपयोग होत नाही. 1 दिवस पेपरमध्ये येतं, त्याला प्रसिद्धी मिळते, आणि त्याच्यानंतर सगळ्यांचे ते वेस्ट पेपर बास्केटमध्ये जातं.
Okay, so it has a very limited role.
Very limited.
And we can now see that this question is for Dr. Raju Joshi, is that we have a law. This is called the Doctor Protection Act, which was passed in 2010, and it is supposed to protect us. And why is it not effective? Dr. Joshi.
Thank you, Dr. Kane, for allowing me to speak. I would like to thank the Research Society for inviting me here, as well as Anesthesia Society for giving financial contribution for the PIL which I filed. I would like to thank Dr. Naurange for giving his guidance and first affidavit that violence is creating problems for us, which has been appreciated by the High Court, and Dr. Pratibha Kane also for giving some financial assistance. So I'm really grateful to all of you, and I'm going to present a little information about the PIL which has been filed. So the Doctors Protection Act was passed in 2010, and we all know that it has not helped us at all. So there was an assault on doctors on 2015, and then I started my LLB course in 2017 because I was attending medical legal meetings in IMA. I was trying to learn medical legal laws, and I was realizing that what we are doing is not enough. It is just not enough, and I need to learn law because whenever I tried to go to lawyers, the fees I heard were exorbitant. So I decided that let me spend some of my time and learn law, and then I can guide the lawyers as to what is required to be done. So as I learned law, what I found was something astonishing. There is a permanent Katara judgment of Supreme Court which says that it is your duty to treat patient in emergency without asking for any financial remuneration or anything. You have to work. It is your duty. In Save Love Foundation order, the court said that it is your duty not to take any phone number or consent or anything from any relative or anybody who brings the patient. You have to treat. When I learned jurisprudence, the jurisprudence says that when there is a duty, there is a corresponding right to you. So that is what I asked the professor of jurisprudence, that I am imposed additional duties of treating patients without money. I am imposed additional duty of treating patients without taking consent. What rights do I have against these duties? They said, none, you have to treat. I said, no, I want to ask for my rights. So I decided to think about how I can ask for my rights, and I studied further, and we learned in detail the Maharashtra Protection Act. Now the Maharashtra Protection Act has 15 clauses in it, and when I studied when I studied the acts of other states, there are total 45 clauses, so which make those acts more strong. And the incidence of this violence in Kerala as well as in Arunachal Pradesh is very low, and the acts are very strong. So in addition, I approached one of my lawyer friends who was my benchmate in school, and I told him that such additional duties are imposed and there is no corresponding right, and in these states there are additional rights given to the doctors, so how we can go about it. So he told me that let us go to High Court or Supreme Court. So I said, I can't afford to go to Supreme Court because fees on Supreme Court is 25 lakhs, 40 lakhs. So he said, don't worry, don't talk to me about fees. I will take some money from you, but we will file a case in the High Court and see the High Court response. So we filed a case in High Court, and the reason was that in government hospitals they are given protection. 700 armed guards are working for the security of state government hospitals. But then there is no protection to private hospitals. So we decided to ask for protection in private hospitals, and then we realized that we should have better protection of law. And that is why we filed this public interest litigation, which is under category of criminal PIL, requested High Court to pass guidelines, because High Court cannot pass any law. But High Court can give guidelines like they gave in Permanent Katara, like they gave in Sevala Foundation. And on the first date of argument, when my lawyer said that you are imposing additional duties, so we want additional rights, the Chief Justice of Bombay High Court said, you are right, you need to be protected, and we will do something about it. So the PIL has been heard for quite some time, and government has agreed to amend the act and add some clauses. Unfortunately, the police has refused to give protection to private hospitals. The police in the meeting said that you make mistakes, so patients beat you. So we said that is not done. We make mistakes means some things happen. We don't do it intentionally. So that has been now taken care of. Now this is the analysis given by police, and they said that you can see percent of detection, nearly 100% work we are doing. So we told them that you give us rate of conviction, and you can see in next slide that only 11% accused are convicted. Now why is the rate so low? So this is the data submitted in affidavit given by the police, and they said that out of 1,381 accused, only 36 have been charge sheeted, 5% charge sheeted, 7 have been decided, and 4 have been acquitted. So why the people go scot-free? The problem is why culprits are not being punished. And the simple answer is the lawyers are trained in law. The clauses of Act of IPC in which there is a sudden and grave provocation due to death of the relative is being accepted as exception or reason for violence. So the lawyer says that, my lord, my client, his brother died, he got angry and he beat the doctor. So suddenly my client is lost his temper and then he beat the doctor. So he gets the benefit of 300 exception for sudden fight, then 334 voluntary causing grievous hurt on provocation, and 358 assault on criminal force on grave provocation. They get relief from the court instead of getting punishment. And what happens is they are given good behavior bond for 10,000 rupees and released. So the rate of acquittal is very low. So what we have done, and you see these sections, these are sections of 80, 87, accident in doing lawful act, act not intended to cause death, act done in good faith, things done in private defense. So we are doing things for patients and these acts are not applied to us by lawyers who are presenting us in the court and the courts who are deciding the cases. So lawyers are taught law, but these laws should be trained to the medical doctors and medical professionals. So they should know that these are their rights. So what we did was, when we studied, fortunately, the Epidemic Disease Act was declared in 2020 and it says there is a presumption of offense. So court shall presume that such person has committed such offense unless the contrary is proved. What is this such person? The person who comes to the hospital premises and beats the doctor. Suppose Raju Zoshisar is on Pune railway station and somebody beats him. Then there is no protection. But when Raju Zoshisar in Sassoon Hospital campus and patient beats him, he has to be protected because he is working there as a doctor. Then the presence of culpable mental state. That means that the patient intended to hit the doctor. Last week you might have heard the news that a patient was waiting outside operation theatre in Bombay. The doctor came out and the patient beat her because she was late in giving certificate. So he was intending to beat her. So that will be presumed. That person has been today released on 10,000 rupees bond by the court. So we want these two clauses to be added in the act. And when we argued before the Chief Justice, he said that these provisions are essential in the law. And fortunately, the Advocate General of Maharashtra State also agreed. So the acts are being amended. And what I feel is, okay. So now Dr. Kani will continue. Thank you.
Okay, so dealing with violence, I will conclude this segment on violence by saying that there are only three things which have proved to prevent or control violence. One is the presence of senior doctors other than the treating doctors, the presence of the police, but unfortunately they are reluctant to give protection to the non-government hospitals and institutions, and the presence of a strong act. So we wish Dr. Joshi all the best to try to strengthen our act. Next, we are moving on to criminal cases being filed against doctors, and they are unabated and senselessly doctors are being charged under criminal law. So what are the changes in the recent years? FIRs are without expert committee opinion of gross negligence. There is indiscriminate use of wrong sections maliciously applied to intimidate, extort money, and settle old scores. Doctors are being punished for even infrastructure deficiencies like fire and shortage of oxygen. Recently, 2 doctors have lost their job because a rat bit a patient in the ICU. Dr. Joshi, now we would like to just understand what are the facts in Dr. Archana Sharma's case which culminated in her suicide.
So we all have heard about this death of Dr. Archana Sharma by suicide. What had happened was the police charged 302 after death of her patient due to PPH. Now that patient, I will not go into the details, but that patient shifted from her town to Jaipur because that is about 300 kilometers travel from her town to Jaipur, 150 kilometers, and from Jaipur back to her town, because Jaipur hospital refused to deliver her if she refused to do tubectomy. And unfortunately, due to that travel, the second stage of labor was prolonged, and chances of, as you all know, PPH increased. And in that case, the doctor treated the patient, and after surgery, after 2 hours, the patient bled to death. After 2 hours, 2 blood units were given, but she could not be saved. Afterwards, what happened was the relatives were happy. They took the body home, and some politicians came back with the body and put it in front of the hospital, and they started doing shouting, and they forced police to apply to 302 instead of 304A, which is medical negligence. So she committed suicide. Now I want you all to understand, everybody who is practicing, that even if you are arrested, worst possible thing, even if you are arrested, you can be discharged or you can come out of the jail in 2 days or police custody in 2 days. That much strength you must have. You are working as a medical professional. You are handling emergencies day in and day out. It is not correct for you to lose your cool and commit suicide. Unfortunately, she did not have that temperament, but we all have to learn from this mishap, and we have to train our students and our colleagues that even if you are arrested by police, you can come out in 2 days. Good lawyers will bring you out. They will take money, but finally you will come out. Okay. You need not worry about the arrest. What happened is, instead of culpable homicide, this 302 was punishment for murder. She was afraid of punishment for murder. Okay. But then due to negligence is, whosoever causes death of any person by doing any rash or negligent act, not amount to culpable homicide. That is under which we are booked and we are tried, and most of the times, if we prove correct documentation, we come out successfully without much problem. Yes, there is some harassment, there is some problem, but we have to fight this mentally and not get subject or surrender to this 302. If they slap on you, you can file in the court that this is not 302, you can 304A, and court usually accepts, but they are better learned than the police people.
So we just have to, I'm going to go a little fast. Whether this event could have been prevented. Like Sir said, that yes, we have to develop some mental strengths. Dr. Naurange is just going to tell us what are the lessons from the Archana Sharma tragedy.
Yes. Go to the slide, please.
Slide naka kadu. Slide by
Okay, the first lesson I think Dr. Raju has already said, that be strong, be positive, and even if you are wrongly applied a wrong section and wrong treatment is given to you by arresting, there are न्याय संस्था अजूनही जिवंत आहे आणि ती तुम्हाला नक्की बाहेर काढणार आहे. And then second step should not be forgotten, that after you come out, after you inform your colleagues, you have to put a counter case on the Commissioner of Police, which we have done in Pune, and then they get straightened. So if wrong section is applied, we have to prosecute the Commissioner of Police and the local, whosoever has applied this particular section. Then the story ends. Number two, I just formulated after seeing several cases that inform in case of any suspected criminal section getting applied to you, inform your friends, colleagues, association and medical legal experts. So don't go to the lawyers, don't rush to the lawyers. They are only for money. मी अगदी स्पष्ट बोलतोय या ठिकाणी. Both of us have done LLB, but we speak from the dais of legal, she has also done it. From the law colleges also, from the dais I say the same thing. आमच्याकडे मेडिकल काउन्सिलचे प्रिन्सिपल आहे, मनी कम्स आफ्टरवर्ड्स. त्यांचं पहिलं काय आहे, यू आर वर्किंग फॉर मनी. सो देर इज अ डिफरन्स बिटवीन द टू काउन्सिल्स. पहिली गोष्ट यांना इन्फॉर्म करा. आपल्याला काय वाटतं, आपल्याकडे झालेलं काहीतरी कशाला कळवा, आपली डेफिशियन्सी कळेल दुसऱ्याला, तसं नाही आहे. Usually you are correct, intentions are right, no doctor has bad intentions. You inform your colleagues, friends, associations, medical legal experts, forewarn them. डोंट रश टू द अँटिसिपेटरी बेल. ही एक दुसरी महान चूक आहे. अँटिसिपेटरी बेल तुम्हाला मिळणारच नाही. अँटिसिपेटरी बेल मिळायला सरांनी मगाशी सांगितलं 304A, जो कल्पेबल negligence not amounting to murder, no, without any intentions, that is a special section for doctors. त्या ठिकाणी बेल इज युअर राईट, आणि तुमचा राईट असताना पोलिसच तुम्हाला बेल देतात. त्यामुळे सेशन्स कोर्टमध्ये तुमचा बेल डिसमिस होतो आणि दुसऱ्या दिवशी पेपरमध्ये मोठी न्यूज येते, डॉक्टरांना अँटिसिपेटरी बेल सुद्धा मिळाला नाही. आता पॉलिटिशियन्समध्ये ह्या केसेस चालू आहेत. तर बेल तुम्ही हा तुमचा हक्क असल्यामुळे तुम्हाला बेल मिळत नाही. सो डोंट गो फॉर अँटिसिपेटरी बेल बिकॉज इट इज युअर राईट. डोंट गेट कन्फ्युज्ड इमोशनल. आत्ता जे अर्चनाच्या केसमध्ये घडलं ते, डोंट कमिट सुइसाइड. वी आर देअर टू हेल्प all and every case. Now here I am bold enough to say that it is not just products of allopathy. Any doctor, whether he is Ayurvedic, a combination, Unani, homeopathic, doctor is a doctor. So we have to protect all out, all of us sitting in this audience, all are BJ medical products, and we are proud of allopathy and modern medicine, but then we have to protect other doctors also. So we are all doctors. To take your time to write the detailed notes. डोंट ओव्हरराईट. ओव्हरराईट वगैरे आपल्याला सेकंड MBBSला शिकवतात की त्या ठिकाणी जर तुम्ही ओव्हर रायटिंग केलं तर ते चुकीचं आहे. स्क्रॅच करा, नवीन नोट्स लिहा, सही करा, बाजूला डेट अँड टाईम टाकलं गेलं पाहिजे. कीप द, आता आपल्याकडे इन्व्हेस्टिगेटिंग ऑफिसर म्हणजे पोलीस आला, त्या पर्टिक्युलर केसमध्ये दे आस्क फॉर द ओरिजिनल पेपर्स. तुम्हाला पेपर्स तुमचे नंबर करायला पाहिजेत, 1 2 3 4 5 6 7 8 9 10. त्या ठिकाणी कीप अ झेरॉक्स कॉपी विथ यू. यू हॅव ऑलवेज सफिशियंट टाईम टू बाय टाईम, बिकॉज देर इज अ क्लॉज इन द एव्हिडन्स ॲक्ट विच सेज memory clause. I think it is section 235 or something, where you are allowed to write the notes from recent memory, that is 2 hours or so. Complete the notes completely. आणि त्यानंतर तुमचा पेपर तुम्ही अप टू डेट करू शकता. इफ द ऑफिसर सेज नो, यू प्रोटेस्ट ओव्हर देअर, ठीक आहे घेऊन चला पेपर, पण नंतर आपल्या नोट्स पुन्हा लिहून घ्या. इट हॅज एव्हिडेन्शियरी व्हॅल्यू. ऑलवेज गो टू द पोलीस चौकी विथ तुम्हाला चौकीवरती बोलावतात तुमचं स्टेटमेंट द्यायला. एकटे जाऊ नका, कमीत कमी 2 ते 3 लोक जा. त्यांची अशी पद्धत आहे की तुम्हाला तिथे रडवायचं. सकाळी 11ला बोलवणार, इन्स्पेक्टर हजर नसतो, टेलिफोनवर घेत नाही, इन्व्हेस्टिगेशन गेलाय म्हणतो, संध्याकाळी 6ला तो रमत गमत येतो आणि मग तुमची चौकशी सुरू करतो. यू कॅन लिव्ह द चौकी सेईंग दॅट आय गॉट अदर पेशंट्स. मी तुम्हाला प्रॅक्टिकल टिप्स देतोय. ऑलवेज गो टू द पोलीस विथ 2 or 3 फ्रेंड्स ऑर कलिग्स ऑफ युअर. डोंट वरी अबाउट द तुम्ही काही पण स्टेटमेंट करा, इट इज लीस्ट एव्हिडेन्शियल व्हॅल्यू. डोंट वरी व्हॉट एव्हर. पण एनिवे ते जे ते लिहून घेतात, तुम्हाला लिहून द्यायचं नसतं, ते लिहून घेतात. त्यानंतर ते हल्ली टाईप करतात. टाईप केलेलं स्टेटमेंट त्यांच्या हातात देताना ते म्हणतात सही करा, शांतपणे वाचून घ्या. तुमच्या बरोबर मॅडम देतात, बाय अँड चार्ज देतात. दॅट इज युअर राईट, बिकॉज यू आर सायनिंग समथिंग विच यू आर गिवन. सो एनिवे इफ दे डोंट गिव्ह, टेक अ पिक्चर. दॅट दे ऑल्सो दे आर अलाउइंग नाउ. Do not worry about the statements made to the police. It has least evidentiary value. Always approach the top officials, which I was coming to that point. Go to the commissioner of police along with your association or your lawyer or your colleagues. खालच्या लेवलला करून उपयोग नाही. दोन्हीकडनं एक्स्ट्रॅक्शन चालतं, ही फॅक्ट आहे. अँड कॉल 100 नंबर. तुम्हाला एकच नंबर कॉल करायचा आहे, 100 नंबर. 100 नंबर का? एव्हरी कॉल इज रेकॉर्डेड. 100 नंबरचा कॉल हा 16 लाईन्स आहेत. या आपल्या डिमांडनंतर वाढलेल्या आहेत. आधी 8च होत्या, त्यानंतर ते 16 झालेले आहेत. 16 लाईन्स आर देअर फॉर 100 नंबर ॲट कमिशनर ऑफ पोलीस ऑफिस. ईच वर्ड यू आर अटरिंग इज रेकॉर्डेड. आता पुढचं सांगतो की तुम्ही जेव्हा त्यांना कळवता तेव्हा त्यांचा बकल नंबर मागून घ्या, नाव विचारा. हल्ली ते पण सांगायला कुरकुर करतात. त्यामध्ये असं करायचं की 100 नंबरला कॉल करायचं, हे मला नंबर सांगा, आणि पुढची स्टेप लिहिले की नाही मला माहीत नाही. यू हॅव टू राईट अन ईमेल टू द कमिशनर ऑफ पोलीस. It will automatically get registered. Date and time automatic register hoto. So these are my suggestions whenever the police are asking you to come or when police come to your clinic.
Okay. These are certain case references that
complete this. Yeah,
please take a photograph of these. These you must have on your laptop or desktop. Keep a printed copy just in case any police comes. You can show them these copies.
This is a very nice slide made by Dr. Kane, and these references required. हे तुमच्या फिंगर टिप्स वर मोबाईल मध्ये पाहिजेत. त्याच्याबरोबर त्याचा फुल व्हर्शन आणि एक तरी प्रिंटआउट बरोबर पाहिजे, या तिन्ही गोष्टींच्या. कारण अनफॉर्च्युनेटली डॉक्टर जोशी तर म्हणतात त्या लॉ मध्ये सुधारणा करा, पण त्याच्याविरुद्ध असलेला लॉ पण आता माहीत नाही आहे.
हां, कोणालाच माहिती नाही आहे.
त्यामुळे आम्ही काय करतो की पोलीस कमिशनर बदलला की पहिलं त्यांना जाऊन भेटतो. यावेळेचं राहिलं आहे बिकॉज ऑफ करोना. अभिजित गुप्ता इज देअर. वी हॅव टू गिव्ह दिस इन्फॉर्मेशन की असा असा लॉ आहे, अशा अशा पद्धतीने व्हा, म्हणजे अर्चना शर्मासारखी केस होणार नाही. तेव्हा हे त्यानंतरच ते इम्प्लिमेंट होतं आणि वी आर ट्राईंग टू टेक आउट एक त्यांच्याकडनंच सर्क्युलर सगळ्या पोलीस चौकींसाठी आलं तरच ते मानलं जातं. तर नाहीतर मग आपल्याकडे रेकॉर्ड तयार पाहिजे आणि ते तिथे सबमिट करून दिलं नंतरच ते मानतात. नाही तर ते म्हणत असा लॉस नाही आहे. पहिलं गोष्ट असतं ते असा लॉस नाही आहे. 2010चा लॉ आहे, 12 वर्ष झाली आहेत, अजूनही अज्ञान आहे. आपण नेहमी म्हणतो इग्नोरन्स ऑफ लॉ इज नॉट पार्डनेबल. इट इज नॉट पार्डनेबल टू यू अँड मी. इट इज पार्डनेबल फॉर द लॉ मेकर्स, इट इज पार्डनेबल फॉर द लॉ इम्प्लिमेंटर्स अँड इट इज पार्डनेबल फॉर द ज्युडिशरी. आपल्याला लॉ माहिती असणं आवश्यक आहे, आपल्याला लागणार आहे. बाकीच्यांना नसलं तरी ते चालून जातं. आपल्याला नसलं माहिती तर मात्र गवगवा होतो.
I would like Dr. Joshi to just make us understand the injustice and the total system failure in the case of Dr. Vishakha Shinde, please.
So, when this Dr. Vishakha Shinde was arrested by police, I had some friends in Nagar and I tried to contact them, and then somehow I reached her father. After she was released on bail, for 1 week she was not in the mental framework even to talk to anybody. So I requested her father that I want to talk to her, but he said that my daughter is not in framework of talking to anybody. So I requested Dr. Prachi Sathe of Ruby Hall, the medical director of Ruby Hall, that being in charge of Ruby Hall ICU, you can make a request to her that what happened in that ICU that I want to know. And then she talked to her father, and her father sitting in front of her, Dr. Vishakha Shinde, opened up and told such things which happened to her in police chowki and judicial custody, that basically 304 and 304A were slapped on her. She was put in police custody for 4 to 5 days. Then she was in judicial custody for about 9 days. In police custody, every day a lady inspector would beat a hardcore criminal in front of her and tell her that accept your mistake, otherwise this will happen to you. This has happened to her. I talked to her about at one night at from 10 to 11 afterwards because I want to take down all the points. And she said that, sir, she said this to me. And then I broke down when I went to the court. And then the court said that you are not answering, then we'll give you judicial custody. In judicial custody, these 3 girls, 1 doctor and 2 nurses, were asked to live in a room in which 15 in prison people were there. 15 women there, about 10 by 15 room. So they did not have place to sleep with legs straight. They had to crouch and sleep like that. No washroom, no place to go for a bath. So every 3rd day they changed their clothes with 2 nurses holding the blanket around her. That is how they have survived those 8 to 9 days. There was no lady inspector in the jail even at night. And finally she was released on bail but restricted to Nagar district. So IMA Pune had filed interim application in Bombay High Court for her release of this bond and quashing of FIR. But unfortunately, because of the jurisdiction reasons, the Bombay High Court said that you have to go to Aurangabad court. So this case is now, trial is going on in the Aurangabad court for last 5 months. So what we have to learn is that there are accidents. This fire was accident. Vishakha Shinde was the last person to be responsible for the accident. The hospital administrator had written to government. We have records from January to October. 15 letters he has written to government requesting for fire fighting equipment, for how to prevent fire and all that. It has not been done. And most importantly, we ourselves also have to understand what is accident and what is negligence. Now, there can be unexpected outcome, unexpected reasons, unforeseen manner, and unintentional injury. For example, anaphylactic reaction. I have in my clinic experienced anaphylactic reaction to test dose of penicillin. Now, people taught me that less than 5 years old children don't get anaphylaxis. I have given a test dose of penicillin, and after giving full injection, patient has collapsed in my clinic. By God's grace, they have survived. But this can happen. Then sudden cardiac arrest, nobody can predict. Athletes have fallen on street and died. So it is not this is an accident. And not related to medical treatment are like fire or fall of a patient, or oxygen is not available, oxygen is consumed, no oxygen available, no beds available. How can the doctors be responsible? And I argued in the court that this is what I told the court, that they said that there should be a protocol for treatment, and I said that you cannot bind a doctor by protocol, because if there is some change in a particular patient, if the response of the patient is not correct, then the treating doctor will have to make some deviation. And then I asked the court, the Chief Justice of the Bombay High Court, that if you make a protocol and I treat the patient accordingly and the patient dies, are you going to take responsibility? This I asked him straightforward by looking at his eyes, and he said, how can I take responsibility? Then I asked him, how can I take responsibility? I cannot. If you fix me to a protocol, I cannot take responsibility. You have to unbind me from a protocol. And he said, yes, you are a captain of ship. You can decide, but just follow the protocol as much as possible. I said, yes, everybody is doing that, but disease is new. There are 5 protocols. Every day protocol is evolving in COVID. So you cannot bind, and that has been done with, and they have told the government that you cannot do this. No police complaint will be filed against COVID-related issues against a doctor. That was told to the government. So we are also, myself and Dr. Navarenge, we are trying to get a medical accident insurance cover so that we are all protected from the accidents. So Dr. Kane, please go ahead.
So in these situations of violence and criminal negligence against doctors, the doctor support organizations play a very, very vital role. Dr. Navarenge, sir, please.
Yeah. मला असं वाटतं मी मराठीत बोलतो, पटकन बोलून टाकतो. आपल्याला सगळ्यांना माहिती आहे, प्रत्येक गोष्टीला डिसीज म्हटलं की त्याला प्रायमरी प्रिव्हेन्शन, सेकंडरी प्रिव्हेन्शन, टर्शरी प्रिव्हेन्शन अशा गोष्टी. सो प्रायमरी प्रिव्हेन्शन इज व्हॉट एव्हर यू लर्न्ड इन द प्रिव्हियस 2 orations. How you should be, how the doctor should be, how ideal he should be. But despite that, the cases are occurring, they are on the increase. It's a practical, hard fact of life. आणि हे फक्त प्रायव्हेट सेक्टरला आहे असं नाही, गव्हर्नमेंट सेक्टरमध्ये पण केसेस आहेत, कन्झ्युमरच्या केसेस गव्हर्नमेंट ससून विरुद्ध पण आहेत. सर्वात जास्त केसेस गव्हर्नमेंटमधल्या PGI इन्स्टिट्यूट चंदीगड भरती आहेत, त्याच्या खालोखाल ऑल इंडिया इन्स्टिट्यूट, तिसरं निलोफर हॉस्पिटल हैदराबाद, अँड सो ऑन सो फोर्थ. तेव्हा कोणीही इम्युन नाही. देन वी फॉलो वॉट एव्हर प्रोटोकॉल अँड दिस स्टँडर्ड. Communication is one of the primary preventions. These are acting as secondary prevention. You should be becoming a member of one of the 3 at least. सगळ्यांचं झालं तर आनंद आहे. त्या ठिकाणी these are your colleague organizations. They have their fixed rules and they will help you in time of crisis. First of all, you have to be upright. First of all, your ethics should be very clear. Your academics should be very strong. You should be attending same age. You have to adapt to the new changes which are occurring. याला पर्याय नाही. पहिली गोष्ट, you have to be strong academics. नंबर 2, जेंटल बिहेवियर एक्सेट्रा एक्सेट्रा. पण हे सगळं गुडी केल्यानंतर जेव्हा खरी केस येते तेव्हा यांच्याकडे आपल्याला लगेच रिपोर्ट करायला पाहिजे. दीज आर द पीपल हू विल टेक यू टू द कमिशनर ऑफ पोलीस. दीज आर द पीपल हू विल टेक यू टू द प्रॉपर ॲडव्होकेट. आपल्याला नीट ॲडव्होकेटसुद्धा माहीत नसतो, तो चांगला आहे का लोटारू आहे, आपल्याला कळायला मार्ग नसतं. सो ह्या सगळ्या गोष्टींसाठी दीज पीपल आर द वन्स विच विल बी हेल्पिंग यू, drafting, giving you expert opinion, making affidavits on your behalf, supporting your treatment protocols, etc. So this is the secondary. The tertiary line is, as far as criminal cases are concerned, you have to take these people along with you to the Commissioner of Police and then come down. Number 2, you have to take the help of appropriate lawyers. And number 3, as far as civil cases, that is consumer cases are concerned, you have to have insurance. So adequate indemnity professional insurance coverage is required for everyone, uninterrupted coverage. माझं असं मत आहे, for general practitioners, nobody general practitioner here, but I'm just uttering the words, 25 lakhs insurance cover. For those who are consultants, at least 50 lakhs. Surgeons, 1 crore. Anesthetists, minimum 1 crore. Every super specialist, minimum 1 crore to 2 crores. Every hospital should have, there is separate indemnity policy. We should for 1 to 2 crores. So ह्या आजकालच्या दिवसात demand of compensation is never less than 1 crore, even from a place like Isalkaranji and all that. So be adequately covered. त्या लोकांचं इन्शुरन्स कव्हर असणं आवश्यक आहे. They will give you midnight sleep.
So Dr. Naurange is going to now make a plea to the government expert committees. It's not coming. Okay. So government expert committees.
I have to comment?
Yes.
Okay. All of us should remember one thing, that as per Jacob Matthews' judgment, which I have mentioned in one of the slides, that should be on your fingertips, it has clearly given the guidelines that no criminal case should be filed against a doctor unless there is an expert committee which gives a prima facie opinion that there could be negligence. आता इथे काय झालं अर्चना केसमध्ये त्यांनी 302 लावला. 302 is direct murder. So over there is no mention of expert committee. But then we should have given, I mean, all the colleagues and associations over there enough confidence that 304A needs to be applied. If at all you have to apply, the Jacob Matthews मध्ये तर clear लिहिलेलं, if at all, see, there has to be decriminalization of medical cases. First and foremost demand we are putting forward is there should be decriminalization of medical cases. हे होईल की नाही माहित नाही, पण आत्ताच्या स्टेजला काय आहे, 304 is there. In that, Jacob Matthews one step further has gone ahead in that another case, which is that Martin D'Souza, which says that if 304A is also wrongly applied, we mean Supreme Court, will proceed suo motu against the erring police officers. ही थ्रेट आपण इथे दाखवली, त्यानंतर त्या केसेस ड्रॉप झालेल्या आहेत पुण्यामध्ये सुद्धा. तेव्हा ह्या ठिकाणी आपण लक्षात घ्यायचं की एक्सपर्ट कमिटी. नाउ माय हंबल रिक्वेस्ट टू द एक्सपर्ट कमिटी ऑफ Sassoon Hospital or at Aund Hospital or anywhere where the government situation is there, is that police cases are getting referred to you. So when police are asking for their opinion, they should clearly say whether there was an element of criminal negligence or not. And criminal negligence is well defined in the Jacob Matthews, that out of 6 levels of negligence, only 5th and 6th is criminal negligence. So I request the expert committees who are working in this, maybe Professor of Forensic Medicine, Professor of Medicine, Professor of Anesthesiology, Professor of Surgery, or the concerned specialty, to give a clear wording that there is a prima facie evidence of criminal negligence. Just saying that date and time is not put, consent does not seem to have taken, याचा अर्थ पोलीस ऑफिसर तुमच्या मनात नसतं, पण पोलीस असं काढतात, 72 injections are given. Actually, that was a good sentence. The 72 injections were given in a desperate situation to save the patient. The police commissioner took it other way, that 72 pricks were given to the patient. And a criminal case was filed against 6 anesthetists and a concerned doctor. Here, who name आमची request है कि is there a gross negligence? Is there rashness or culpability? Is it enough to put the patient behind bar, doctor behind the bar? This should be made clear, whether there is an element of criminality in this. It is a question of doctor's life, as you have seen in Archana case, that she took her own life. Practice, reputation at stake. Please allow him to appear and explain his side. Now these are the guidelines by NMC and MCI. They are not mandatory. I admit these are not mandatory at all. Because ultimately you are not court. These are an expert committee. You are going to give opinion on the paper submitted. But these are the guidelines which are accepted by NMC. आता त्याच्याबद्दल कधी हे येईल ते बघूया, GR येईल म्हणा किंवा काहीतरी रेकमेंडेटरी रुलिंग. पण till then, if we go behind that police have referred a case after the postmortem, after the chemical analysis report, we earnestly request the expert committee to give an opinion regarding the criminal negligence. Of course, there can be a reference given by consumer court also, that whether there is element of negligence or not. Of course, in that case, you can mention that there is an element of medical negligence or not.
Shall I have a word with this?
All right. I'm going to just conclude.
Sir wants to say.
So, as sir has pointed out regarding criminal negligence cases which are referred to the committee, most of the time the committee take all the deliberations into consideration, whatever the notes that is being submitted to us, and most of the time they look for only gross negligence is there or not. As you said, no one looks for date and time and all these things. Whether, because criminal negligence specifically says whether there is a gross negligence on the part of registered medical practitioner, then and then visually the report is given that there is an element of criminal negligence involved in that particular case. Otherwise, no one...
Thank you, sir. Thank you so much, sir. But these are the cases of this hospital 7 years back. So I'm mentioning this because it has happened in a dental case.
Yeah.
That consent signature is not there. See, then police arrested him. That is what I mentioned this, that we are doing a great thing. you are well knowledgeable. See, this is where knowledge and information and wisdom makes a difference. Who is there in that committee? So same way we expect everybody to function. Thank you.
So there is an appeal to all, Dr. So in our sphere of influence, we must have zero tolerance for violence. We must rush to help any doctor in need. And besides clinical knowledge, be increasingly aware of medico-legal developments and lend financial support for legal recourse efforts by medical organizations like Dr. Raju Zoshisar is doing, and take appropriate steps for a safer future. File FIR. If the police do not do it, file a private complaint. So we are done here, and we have concluded. I would like that all of us together, we must change this course of destiny. Dr. Joshi, would you like to just end?
So those of you who want to learn something about medico-legal, we are starting a course on 30th of April, which will run for 11 weeks, every Saturday for 3 hours. So anybody is
Next slide, please.
So anybody who wants to enroll for the course, please take down my mobile number and send a message to me, and I will send you details of the course. And those who are interested can participate in the course. It is every Saturday for 11 Saturdays. So I think it is most convenient time, 2 to 5. So all of you are cordially invited. Both Dr. Naurange and Seva Khan will be faculty in those courses. Dr. Janjad will also be there. Thank you so much.
Thank you, Joshi sir. Thank you, Naurange sir. Thank you, Madam, Kane Madam. So you have given a very nice and detailed description regarding the negligence, how to prevent negligence. Even if cases happens against the doctor, how to face, in what situation, how to respond to that situations. And thank you very much, Joshi sir, for filing a PIL, which would be helpful for the private practitioner, registered medical practitioner, to cope up these situations where they might face the negligence cases. Thank you once again.
Thank you. We were hoping to see more residents here. Actually, the whole thing was targeted for their practice, but it's all right. I think everybody needs this information. Thank you, sir.
Thank you all. Thank you.
Thank you, speakers. I request Dr. Naresh sir to kindly felicitate Dr. Rajiv Joshi sir. I request Dr. Sanjay Gaikwad sir to felicitate Dr. Pratibha Kane madam. I request Dr. Harish Dhatia sir to felicitate Dr. Jayant Navrange sir. I now request Dr. Sureka Chavan madam to felicitate our chairperson, Dr. Naresh Zanjad sir. I request Dr. Sunita Khade madam to felicitate our chairperson, Dr. Sanjay Gaikwad sir. I request Dr. Kirti Kundalwal madam to felicitate our chairperson, Dr. Harish Dhatia sir. Moving on to our next session. Over Over the last decade, there has been an increasing interest in the enthusiasm and point-of-care ultrasound as an aid to traditional examination techniques in assessing acutely unwell adult patients. The advent of smaller, more portable machines combined with improved picture quality has brought ultrasound out of the radiology department and into the wards and casualties. Today, we have with us Dr. Amit Dikshit sir, who will throw some light on ultrasound in perioperative and emergency medicine, point-of-care ultrasound. I request our chairperson for the session, Dr. Surekha Shinde Madam, Professor, Department of Anesthesiology, Dr. Kiran Kumar Zadhav sir, Associate Professor, Department of General Surgery, and Dr. Sanjay Munde sir, Associate Professor, Department of General Medicine, to kindly come on stage and give us an introduction about our speaker, Dr. Amit Dikshit sir.
Good afternoon all. On behalf of organizing committee, I welcome you all for this session on point-of-care ultrasonography. Dr. Amit needs no introduction for anesthesia faculty, but for the purpose of people who don't know him, who are not in anesthesia, I request Dr. Kiran Jadhav to introduce his CV, and we are all eager to know about him. He's a man of action, man of performing different skills in anesthesia. Thank you.
Good afternoon to all. May I introducing Dr. Amit Dikshit. He is an anesthetist and postdoctorate regional anesthesia fellowship from the Ganga Hospital. He is a consultant of anesthesia and acute pain specialty in Ruby Hall Clinic. Dr. Amit, he is a member of Board of Studies, Research and Fellowship of AORA, PS Review Journal also, and he is also Executive Committee member of AORA. He is a course director for the Regional Anesthesia Workshop in Ruby Hall. Also a course director for several workshops on basic and advanced endocardiography, and he has contributed chapters in POCU Handbook of Anesthesia. So I request Dr. Amit Dikshit to have their talk. Thank you.
Thank you very much, sir. You can start the slide, no problem, slide. So at the outset, it is my pride and honor to be part of this gathering. Point of care ultrasound is very close to my heart. I am trained in regional anesthesia and ultrasound from various institutes. I did my PG initially from Sion, and then I was in Hinduja, I was in Leelavati Hospital. Later, I joined fellowship in Ganga Hospital. So I am indirectly student of BJ because I am student of Bala Venkat sir. And I am really glad Dr. Bhalerao madam, Dr. Surekha Shinde madam, and Kedkar madam, and all the renowned faculties from city of Pune who are sitting here for this lecture. Thank you very much. Now today morning I was listening to various talks. Previous was a discussion on medico-legal, and I think what else you can think of ultrasound if you're really thinking on lines of medico-legal thing. Secondly, we want then the morning oration lecture, there were challenges like mobile phone and app. So without wasting much time, I would like to start that how we can create interest in our own community and inspire young minds for better patient care. So I have greetings to you all from Ruby Hall Clinic. When it comes to ultrasound, it requires a little bit of intellectual conviction. When I first joined Ruby Hall, you all may be thinking that we already have all the gadgets. With our department especially, it was not so. We were struggling because nobody was trained to use ultrasound. So what I am trying to suggest and highlight is, first you train yourself and then you can get an equipment. So initially there was this fear of PCPNDT. My HOD asked me if there is any medico-legal issue, are you willing to go to jail? So I have this training of ultrasound, and I have clear conviction, intellectual conviction, that this is an useful gadget and I must pursue it, I must use it for patient care, and I am doing nothing wrong. We will follow all the formalities. So for the first time, to PCPNDT Pune, whole department of anesthesia with all 13 consultants wrote a letter. They took a committee meeting, and we got whole of the department recognized for PCPNDT in 2013. So this was the initial step where we made all ultrasound savvy. So regional anesthesia and orthopedics, this was one case, and we are in the era of enhanced recovery and regional anesthesia. Patient has undergone TKR surgery, and at the end of 3 hours, you can see he's able to walk. Now this is magic of ultrasound, where we are in the era of site-specific anesthesia and analgesia, and we have done an adductor canal block, which is a motor sparing block, local infiltration, and an IPAC. Another case, which was, a polytrauma, surgery went on for 9 hours. Patient had an elbow fracture and a shoulder fracture, and we did it under block, and at the end of surgery, the patient was absolutely pain-free, smiling. We have placed a perineural catheter, and we have started an infusion with a balloon elastomeric pump, and for next 72 hours, patient did not require anything other than 1 single dose of paracetamol. I am here to highlight, somebody would say, these are gadgets only with corporate setup. So I'll share a small story of mine. I was teaching and training this venture, this ultrasound and POCUS approach to all my students. One of my PG student, who was just 6 months of training, he went to his hometown in Brahmapuri area, and near in that area there was one the fracture elbow case, and the cousin brother and the anesthetist there requested, you are being trained in regional and all that, so will you be able to do a block there? So then, as you know, the enthusiasm of a first year resident, he said, मी ब्लॉक देऊ शकतो जर अल्ट्रासाउंड मशीन देणार असाल तर. So that level of confidence was there even with 6 months of training. And to his utter surprise, it was a nursing home, and down was a radiologist, and they also had the ultrasound machine, and machine was brought up, and with the help of senior anesthetist alongside him, he performed a block very well. So those of us who are thinking that ultrasound is not possible, so we have a very good example in AORA, Dr. Surjit Giri. Surjit Giri invited us to his place in Assam, and there he was, he said, we asked how many delegates are there. So he said there are 250 delegates. We were wondering how come 250 delegates. So when we went there, we saw all the people from the town and all the authorities sitting there. So he told them that please let them know that this is an important gadget. Jilla Pradesh Adhyaksha and governor and all them. So they were sensitized, and then they bought the machine there. So I mean, we can sensitize. So now we are in the era where we do not wish to auscultate the patient, primarily to depend and end our examination there. So auscultation is first step, and last step probably could be to put an ultrasound probe. So I'll share my transformation. When in 2013 I came to Ruby, and I was there in Vanori hospital, and it was like busy days of Diwali, and we had a very serious patient with bradycardia and posted for decompressive craniotomy, and there was an ultrasound machine, echo machine, and patient was having ECG changes. So I said, I need to know echo findings. Then they tried contacting the resident echocardiographer, and there was a lot of delay, and it was an emergency case. Finally, we pushed the patient inside. But that has led me to introspection that machine is there, patient is there, and I need to know few basic things. So it has changed the way I look at patient care, and then I got myself trained into echocardiography. In last 2 years of COVID, we have trained all our PG residents in echocardiography, basic echocardiography. All my consultants are trained in basic echocardiography. And I was really happy to tell you that when this echocardiography training was done, somebody said, अरे यांना अजून इंट्युबेशन येत नाही, यांना अजून स्पायनल देता येत नाही, they are not able, so trained in, how can you train them to echo training? So I mean, this is a gradual process. If you take a case of a child and they are multilinguistic, if you expose them to different languages, they will pick up quick. So this has to be imbibed during the PG training itself. So I'll tell you one more success story. This was one of my resident who just completed DA with us. And during COVID time, he went to Selu, and then there was one hospital in Parbhani. And there was no doctor, no cardiologist to give, to check the patient and give clearance. It was just a 10-bedded ICU and 2 OTs. So he did echo, he recorded it on WhatsApp and forwarded it to the cardiologist. The cardiologists were so happy and they immediately cleared the patient. So this is improving the patient care. They are putting central line, checking the swirl sign, looking at the echo, and this is very, very important. When I was in AFMC 2 years back and I was discussing with one of the commander there, he said, this is very important for us. Sometimes we are the sole physician in the hospital, and putting one echo probe, diagnosing a condition, it makes us absolutely independent. So I mean, we have to make ourselves eco-literate, ultrasound literate, and this is the need of the hour. Fluid assessment, as you may be knowing, we do IVC collapsibility. Now, how this can affect outcome in COVID pandemic, because we have seen this. Now, initially, in the initial first wave, everyone was worried about, we do not wish to intubate the patient. So we had this patient who was for cesarean section, and this patient was in severe hypotension. So we looked at IVC, we did the IVC measurement, and it was under leadership of Dr. Kapil Jirpe, and patient was resuscitated so well that we could give spinal. Otherwise, intubation in that situation was necessary to save the life. But just because hemodynamics was looked at very well, and it was a focus approach, so we could do that. So nowadays, when before extubating a major case or a long case, we would like to check the lung water. Sometimes, in robotic radical prostatectomies, major laparotomies, where we think probably patient may have impending pulmonary edema or something, we give Lasix, we give mannitol, and we can predict which patient will have better outcome. So this is very, very crucial, where we can, nowadays, we don't depend on X-ray. Many times in COVID, this we have experienced that it is a time-sensitive thing, something like pulmonary embolism, something like pulmonary edema, pneumothorax, massive MI. We need to pick it up very quickly, what has happened to my patient. After giving spinal, something has happened and there is flatline. I need to know what is the problem. So, I mean, little bit of training. We are not competing with cardiologist or radiologist or anybody, but basic echo understanding, basic ultrasound understanding will change the way we look. Now, this is also, we do bladder ultrasound, fluid assessment, and is not complete unless we look at bladder. Sometimes the catheter may be kinked. And even we have started putting colors and we have started identifying the ureteric jet. This is even, it can tell you, fine-tune you, whether which kidney is functioning, and it is really rewarding. Now, sometimes somebody was telling, previous speaker was saying that, the residents are busy on mobile phone. So these type of things do attract residents, and they are enrolled with the case, and they are very, very aggressive with treatment. Now, pulmonary embolism, I'll share another story. Now, this was a robotic radical prostatectomy which was going on, and it was a very VIP patient, some ex-pass ISCCM president, and he was getting operated, and suddenly we had this flat line. And as you can understand the VIP syndrome, the intensivist, the cardiologist, everything, everybody was standing outside the OT and everyone was looking at us, what you have done. And we could just pull in an echo machine and place a probe, and we could see dilated RARV, and we could diagnose pulmonary embolism. Most of the time pulmonary embolism is an autopsy diagnosis. So once we showed them those images, saved those images, it also has got some medico-legal significance. Everyone said yes, anesthetists, and they are doing the job perfectly. And then patient was treated, next day patient got extubated. So you need to know when these are bedridden patients, sometimes the days, OT days get posted in a busy hospital, like any corporate or a private or a government hospital. So deep vein thrombosis is a very common phenomena. 2-point compression test, one over femoral, one over popliteal, and you just see, and if you can see a thrombus which is appearing as an hyperechoic thing, we can take corrective measures, we can explain the risk to the patient, and these are some of the causes for sudden death in a patient. So what is POCUS? So POCUS means it is a specific question: why my patient is desaturating, why my patient has hypotension, why is this tube, I'll be able to intubate this patient, what should I give fluids or should I start inotrope? So you should have a very sharp question, then you will have a sharp answer. It is not like assessment of whole cardiovascular system. So POCUS approach is a POCUS question. So you have one question, and to that it is a time sensitive thing. We are not here to delay CT scan or MRI, but it is just quick trauma patient, quick scan, and during the primary survey itself you can finish a quick scan and see, oh, there is a blood in the peritoneum, needs laparotomy, something like that. So it is time sensitive, life saving, it is limited evaluation, so you can document it, that limited evaluation suggestive of such and such. So the POCUS examination showed that there is pneumothorax. Now so it redefines the differential diagnosis and it helps in guiding treatment. COVID pandemic, we have saved many patients, and this was even with whole of my ICU team, I discussed with them. Pneumothorax was diagnosed on ultrasound and most of them were treated because radiology technicians even were difficult to get during COVID pandemic. So what is the evidence? POCUS has terrific evidence. You take up any paper in cardiology, in anesthesia, in ICU, in emergency medicine, there is hardly any department which is not touched by ultrasound. So we have acute pain evidence, we have gastric ultrasound and evidence for gastric ultrasound. So few days back there was one patient who came for obstetric emergency cesarean section and patient just had upma 2 hours back. So I was saying that this patient is high risk. If possible, can we wait? If it is in, I was discussing with the obstetrician, but obstetricians do have their own notion. So then I just showed them the gastric content and they said for the first time in Pune city, somebody has showed me the gastric content and I told them, see, this is high risk for aspiration, it is a solid content. So now I have trained and I have spent very serious teaching time with my obstetricians, with my oncosurgeons, with my radiologist, with my intensivist. So when we ask for anything, say we sometimes previously used to share machine with my intensivist. So we have this academic relationship and we help each other. So radiologist for the first time told me that never in their life they have seen a nerve when we have showed them several nerves and nerve block. So I think in our department, in our hospital, we have formed a POCUS group where we have a pulmonologist, a radiologist, a neonatologist, and those who are POCUS enthusiasts, and they interact. So we do have these interactive sessions. So the basic aim of POCUS is there is some indication why my patient is desaturating, something like that. There is image acquisition, there is interpretation, and there is medical decision making. So this is IM. Now this has been used for all the POCUS interventions so far. And there is, now this was one of our high-risk patient who came for bariatric sleeve surgery. So with use of ultrasound, where we can do a single puncture, spinal, single shot block in one go. And these challenging patients are very well fine-tuned and they can be sent. So bariatric patient at the end of 3 and 4 hours, he has received an erector spinae plain block for pain management. And he has started mobilizing, even in the recovery area, he said, I can move on, I have no pain. So he was just discharged in 72 hours and not required any pain medication. So emergency area, yes, airway has been always a challenge and everyone should have working knowledge of how to do a cricothyroidotomy, how on ultrasound you will have this first as a thyroid cartilage in a parasagittal scan and a cricoid cartilage, and in between is the cricothyroid membrane. And this you can see this cricoid cartilage and then there is a step. So this is how we identify the cricoid cartilage. And this is very crucial. Now this was one of our patient who came for neurosurgery and patient was in stridor, couldn't lie down. So we have to mark the cricothyroid membrane. Sometimes in very high-risk patient, we have done a prophylactic cricothyroidotomy. We have placed a 18-gauge gelco just to, ensure that we can able to oxygenate the patient, and did a fiber optic in awake sitting position. So this has given us little bit more leeway, little bit more time for these procedures, and it has been extremely beneficial. Nowadays, when my PG or any junior is intubating, I just park my probe like this, and I see here the esophagus and the trachea. So this is a very sensitive interrogation. If the tube has gone in esophagus, you will immediately pick it up. If it has gone in trachea, it shows double trachea sign. So this has been a part of ACLS guidelines nowadays. And previously we thought that, we need to give umbu the patient to identify whether breaths and EtCO2. So here you can have, even before the first breath, you can confirm where the tube has gone. Now there are other finer aspects to it as well. In pediatric patients, whether the tube has gone endobronchial or not is always been a challenge. And you can see just by placing the probe over sternum, where it is not much calcified in that age group, in adolescent group, you can see the movement of diaphragm very well. And you can see that, the tube is very well placed. Diaphragmatic assessment for inspiration and expiration, for you can see the movement of diaphragm, and you can put it on M mode. So you know the strength of diaphragm, whether we can extubate this patient or not, can be very well. So I was just talking about the gastric ultrasound, and gastric ultrasound is very easy. I'll show you how the gastric, so it is done in the epigastric area, and this was the initial, I'll just show you the initial, we have asked the volunteer to drink water, and then we have assessed the pyloric antrum. And there are, you can actually very well see in the right lateral decubitus position just near the liver. And there are validated studies to show that when the volume is more than 100 ml, there is risk of aspiration or presence of any solid content. So this is gazing star sign, and this patient, we calculated the volume, it is around 400. So emergency patients, when they are pushed in casualty, we should be very, very careful intubating and want to avoid all those catastrophes. Central line, art line, venous line, whichever is your specialty, is very, very important. What ultrasound has done to us is we have started moving back to the cadaver lab. We have started looking more at the anatomy now, and we are reading. So when we put venous cannulation, we know the anatomy of hand very well, and it's an in-plane needling. And we also do the swirl sign, and this is the agitated normal saline which is pushed, and you can see this is RA and this is RV. So micro bubbles moving from RA to RV, it confirms that your central line tip is very well inside. So I'll just play the video one more time, and if the swirl sign is positive and it is less than 2 seconds, then it is probably it is in right position. If it is more than 2 seconds, probably the tip may be somewhere else. So you have to scan axilla, or the opposite side IGV. So these are some of the steps which can fine tune your treatment, your protocols, and we are feeling so confident while using this central line intraoperatively. Otherwise, without an X-ray, we always have this hesitation, where has it gone? And we do not wish to cause any complication. So even the arterial cannulation, I have a story with arterial cannulation, and I must share this with you because how things are changing nowadays. With ultrasound, you can put an arterial line very well. Now this was one of our senior consultant. Some of you may be knowing Dr. Agashe. He has now left the department after COVID. He was a senior consultant. So he just called me one day, and he was first on call, I was second on call, and I was really surprised how sir could call me. And then there was a patient with IVC rent, and patient had a lot of bleeding, and they were not able to find arterial line. When I went there, I just got an ultrasound machine, and all the prominent sites were utilized, and patient was cold and clammy. So no dorsalis pedis, no wrist area. So I could go more little bit proximal, and I placed with an ultrasound out of plane technique. And first reading was like 59 by 29. And, once the line was in place, we could do a goal-directed management of this patient. And it was fluid and inotropes. And Dr. Agash's stretcher, it was fantastically managed. Patient got extubated next day. I mean, this type of skill set will save the patient, and it will help you, and it will give you too much of satisfaction. Now, very well, radiology, shifting to a radiology suite during the COVID pandemic is very difficult. So everyone should have working knowledge of how the pneumothorax is and how we can diagnose pneumothorax. So I'll just show you, there is something called as pathognomonic sign, which is lung point, and you can see here the pneumothorax part and the normal lung part and how it is moving. Similarly, you can see the same thing where the pleura is moving only halfway and that remaining area it is. So this is the lung point. So if you get a lung point, you are very, very sure that at that point of interrogation there is pneumothorax. And it is a very sensitive test. You can pick up as less as 20 ml of air as well. Flaps area is very important. Why I am teaching and letting you know, this is only pattern recognition. The curve, the training, the learning curve with ultrasound is very, very less. You do 2-3 workshops, get acquainted with the faculty, and you will pick up those skills. So everyone can appreciate that this is a a pneumonia, and there is a lobar hepatization and an air bronchogram. So even one slide and one patient can teach you. So this is a pleural effusion and an atelectatic segment, and you can use recruitment maneuver, see whether the lung is getting good amount of filling or not, and pleural effusion tapping. Even the cardiologists do call us for tapping, because as a regional anesthetist we are better with needling, so we are getting these calls from ICU as well. Viral pneumonia has taught us many things, and we used to do a background scan for thickening of pleural line and subpleural pneumonias, and it is very easy that yes, this patient is little high risk. We were worried, so we were calculative about the fluid dynamic part, and these are susceptible to pulmonary edema and things like that. So POCUS training is very, very crucial, though it is not at all difficult, but you need a motivated mentor, and then you can have a spine-bound model, you can teach and train them. It is only pattern recognition. You have to take interest, and in our hospital it is not at all difficult, because if you are interested, you can visit an intensive care area, you can visit radiologist, you can discuss with them. Some of you, your friends may be radiologists. So this is a life skill, I would say, which can save you from many occasions. So we have generated this corn gelatin cake model. This is a recipe is available on internet, and this corn gelatin cake, phantoms are costlier, and our residents are practicing needling, because we put central lines and art lines, and we need to know how needle should be. So needle is very well seen, and you can prepare it, and it stays there for 7 days. So few slides, 1 or 2, I am letting you know, when it comes to pediatric department, we have done scanning for neonates, how to differentiate between transient tachypnea and a respiratory distress syndrome. You can see B lines. We have given surfactants, and B lines have gone down, and it has changed to A lines. So we can titrate the dose of surfactants. This is into neonatology. And we are enrolling our neonatologist also as a part of POCUS program. And inside operation theater, we have a good working, fantastic culture. So we have even placed lumbar puncture for neonates and placed catheters there. You must be aware that, in a neonate, if you do a puncture, then there is a lot of hematoma. It is difficult to get the lumbar puncture next time. So I think it is very good idea to do it. You can even see the catheter here, nicely placed. So this was 110-gram baby, and we have placed it for refractory meningitis, and cholesterol was administered through this. So this was a Kasai procedure where we have placed an epidural catheter for pain management, and you can see the epidural catheter very well with ultrasound. The baby was extubated, baby was pain-free and comfortable at the end of procedure. ICP and Neuro Monitoring, prone position ventilation for longer duration in COVID, and ICP monitoring can be done very well with optic nerve sheet diameter monitoring, which is said as a non-invasive way, because optic nerve carries all the meninges and it carries subarachnoid fluid near. So if we could monitor the patient, 3 millimeter behind the globe. If diameter is more than 5 millimeter, then it is suggestive of raised ICP. So all those patients with, steep head low, surgeries more than 5 hours, or where we have seen papilledema, some patients with raised ICP, we can monitor these patients very well, and this has been a very useful investigation. And you can have an ultrasound probe over there, you can just put a tegaderm and you can rotate and get it. Another intervention where people are very much fond of is you can even put color and see the central retinal artery and central retinal vein, and this is very crucial in long duration prone position or in scoliosis surgery, where in high risk CKD or diabetic patient, you need to document it pre-procedure. This is consensual light reflex. This was a patient with black eye, and because black eye cannot be opened up for pupillary assessment, so we have just placed the probe over the black eye and we have elicited the light reflex in the normal eye. So this is a consensual light reflex, and you can see this pupil constricting with light. So in those black eye patient where we cannot open and see the pupil, just placing the probe and putting light in the normal eye, we can elicit this, and this is very important when we have to decide for neurosurgery. So transcranial Doppler is another extension, and we have doing pulsatility index and patients with subarachnoid hemorrhage, brain death. POCUS is very useful in obstetrics. Now this I was telling you about the example of an AFMC professor who told that in the Pondicherry, in the Port Blair area, he was alone, and just placing the probe over there, you can pick up placenta previa and what is the presenting part, and this can help, and it can serve as a triage that if we do a lower segment cesarean section, patient may bleed torrentially. Some of the patients coming to government hospital directly come for cesarean section, they may not have any ANC checkup. We have picked up cord around necks, and when there are cord around neck, we tell the pediatrician beforehand, before delivery, that see there is cord around neck. By putting a color, you can pick it up, and they keep all the resuscitation gadgets ready. So this has been a breakthrough. Now I'm coming to limitations. Yes, there are limitations because training and credentialing with point of care ultrasound has always been a challenge, but I am sure many institutes and societies are picking up. Morbidly obese patients, subcutaneous emphysema, surgical dressings are some of the limitations, and there is a take-home message. The take-home message is the theme, and we want eternal vigilance and patient safety. I think I have touched upon the important aspects so that you all are encouraged to do more and more point of care in the betterment of our patient. If you are really keen on having some hands-on skills, I think for PGs, just like as we do ACLS and BLS training, this is similar. We should do a basic echo training and a basic ultrasound workshop training. So thank you very much for patient hearing. Thank you for this opportunity. I am the program lead, the faculty lead for another workshop, one in Coimbatore happening on 5th of May, and second in AORA, it's in Mumbai. So it's a one-day whole workshop of point of care ultrasound. So if you're really keen, we'll be happy to have you. Thank you very much.
Hello. Thank you, Dr. Amit, for such wonderful deliberation regarding point of care, ultrasonography in patient care. Actually, indications are limitless. And anything you can think of, and you can use POCUS there. Yes. Actually, anesthesiologists who are confined to operation theatre as hero, now coming in forefront as perioperative physicians. And I think the knowledge and skill about ultrasonography is a very life-saving skill in anesthesiologist's armamentarium. We just diagnose, or we just suspect, we diagnose and treat there and there only, and just we are successful in taking advantage of that golden hour, right? Yes. So I feel very proud, Amit, you are doing such a wonderful job. And just happy to announce that even Department of Anesthesiology, BJ, has owned their own ultrasonography machine. And yesterday we had a full day workshop of sonography skills. And maybe next year in Research Society conference, we'll be presenting more and more papers concerning USG skills. And no wonder this life-saving skill has been a very wonderful I would say skill. So we have ACLS, who always have ultrasonography skills, and all international trauma care has included EFAS, that is Extended Focused Ultrasonography in trauma. So thank you, Amit, thank you very much, and we expect your cooperation in helping us.
Surely, I'll be more than happy.
Please.
Thank you so much.
We are in the learning curve now.
Absolutely.
Thank you so much.
Thank you.
Yeah.
I now request Dr. Prajakta ma'am to kindly felicitate Dr. Sureka Shinde ma'am. I request Dr. Pragya ma'am to kindly felicitate Dr. Kiran Kumar Zadhav sir. I request Dr. Nupur ma'am to kindly felicitate Dr. Sanjay Munde sir. We now move on to our next session. While saving and planned expenditure is the key in pursuit of financial goals, making smart investments with your money makes them much more attainable. The first step in successful investing is figuring out your goals and the risk tolerance, either on your own or with the help of a financial professional. And here we have today the expert, Dr. Kedar Marathe sir, to talk on financial freedom for doctors, a WealthCon passive investors initiative. I wish to invite our chairpersons for the session, Dr. Rajesh Hire sir, Professor and Head, Department of Pharmacology, Dr. Shilpa Naik Madam, Associate Professor, Department of Obstetrics Gynecology, and Dr. Satish Chitore sir, Assistant Professor, Department of Ophthalmology, to kindly come on stage and introduce our speaker, Dr. Kedar Marathe sir.
Hello. A very good afternoon. I welcome you all to this post-lunch session. Indeed, it's my proud privilege to introduce our next speaker, Dr. Kedar Marathe, who is an ex-BJite. He's a BJ alumni and, of course, from the OBGY department. He's a consultant obstetrician and gynecologist and endoscopic and IVF consultant at the Oyster and Pearl Hospitals, Pune. He has done enough trainings in gynae and laparoscopy from Kiel University, Germany, and advanced endoscopy from Beams, Mumbai. Also, he has a reproductive medicine fellowship to his credit from Surat. So I welcome him, and he's going to talk to us on a different topic, financial freedom for doctors. I welcome you, Kedar, to your own platform.
Thank you, ma'am, for kind introduction. It gives me immense pleasure to be here on this dais. It's always an honor to be a speaker in your alma mater. I could see a lot of my teachers, my senior colleagues, my juniors, and now a lot of youngsters, students and residents attending this session. So I would like to begin with my session. Just a moment. So, as we say that darkness to light, ignorance to knowledge is something which is important. And this is so much important when it comes to finance. As doctors, we all are getting educated in our fields right from the beginning, and maybe our education goes on and on and on, maybe till the age of around 30 or sometimes even more. But unfortunately, we have no education or no exposure to the financial knowledge or any kind of financial concepts. So that is something which I am going to today talk about. I'm a gynecologist and I'm an educator and a guide in something called as WealthCon. Probably some of you might have heard something about WealthCon. Now, WealthCon is not something like a financial advisory group or something like that. It's a group of doctors. There are more than 50,000 doctors associated with WealthCon. And what we believe is educating everyone and making them self-reliant. So everyone who is part of this whole program is gaining knowledge with their peers, seniors, in this field of finance. They're all postgraduate MBBS doctors, and they're gaining knowledge, and they're using that knowledge to make themselves self-reliant in the field of their own financial management. So I would begin with my presentation. Now, we have to understand there are certain myths about finance. One of the myths is money is not important. Now, is it really so? Then it is not. We understand money is not the only important thing, but yes, money is really important. And that is something which we have to understand. Wealthy people are bad. That is one more myth many of us do have. Now, it's not really like that. People are good or bad. Wealth doesn't make them bad. Either it doesn't make them good. So wealth itself is not bad. Share market, when it comes to finance, we keep on hearing about that share market is gambling or it is satta. But it is not really so. As again, same way I would say, people are gamblers. And people are gamblers inside the share market, outside the share market. People are gamblers in different fields. So share market is not gambling, it is business. When it comes to business, it has financial rules, regulations, and the same way people earn money in any other business, people can earn money in share market as well. Finance is difficult. This is again a very common misnomer. We all doctors feel that no, finance is something Greek and Latin for us. But then, is it really so? We are not just MBBS postgraduate doctors, and we have been through such tough courses that I don't think finance is even 10% of what we have gone through. So if we have got to super specialty, then I think finance is something really, really simple for us. Another myth is we need a lot of time to track investments. We need a lot of time to manage our own finances. And I don't think so it is really like that. In a day, we might need around 15 to 20 minutes maximum in a day to track our finances, to plan our finances, even for trading, anything which is high-end like even a futures and options trading in share market, we may not need more than 15 to 20 minutes a day. And I myself can tell you I'm a gynecologist, laparoscopic surgeon, infertility consultant. I'm practicing full-fledged, full-time, and still I am able to manage my finances without spending more than 20 minutes a day. So all these are myths. And when we know that these are myths, they generally come out of ignorance. They come out of lack of knowledge. They come out of some kind of fear about managing our own finances. And we have to understand that we have to become self-reliant. We can't be dependent on others. We can't be dependent on somebody else to manage our money. If we are earning, our hard-earned money is to be managed by us and not by somebody else who does not care for it. We are the ones who care for our money, and that's why we are the ones who should manage that money. Now, what are the goals? So if we come down to goals, basic goal is wealth creation. Now, we have to create wealth, and that is what every one of us eventually aspire. Now, how can we do that? There are three simple things which we can talk about. We can say that there is first thing which is asset creation. So creating an asset. Second thing is we have to protect the asset. Even our health is an asset. So we have to have a health insurance, right? Because if we don't protect our asset, which is like our health, probably a lot of money will be eroded in protecting that. So a medical insurance is something like a protection of our asset. And the last thing is saving tax, because we earn a lot of money and we end up paying a lot of tax. So I'm saying legally saving tax. Government has given us a lot of avenues by which we can legally save tax. Paying tax is extremely important. It runs our nation. But then if we can legally save tax, I think it adds to our capital, which will eventually help us to build more and more asset. Now, when it comes to asset, there are again three things. First is saving money. Now, saving is not just enough, because we may save, but if we don't invest it smartly in a way to create better percentage returns, we will not be able to create a bigger asset. And the last and the most important thing is time. If we are invested for a longer duration of time, it gives us immense advantage over somebody who is invested for a shorter duration of time. So if I see the youngsters here who are maybe in their late 20s odd, if they start investing now, I think they can create wonders. So that time is something which is very, very important. Now, coming to the last two things, what we talked about before we come to asset, because that is a little more complicated and that is something which is more important. We have to understand that insurance, that is protection of our wealth, is something which is important. So term life insurance, which we generally call it as a life insurance, is something which is important. All of us should have life insurance, and generally we say it should be around 20 times our annual liabilities. So if we need certain amount of money in 1 year, 20 times of that should be our insurance coverage. So if I suppose my annual say needs are 10 lakhs, then I need to have a 2 crore coverage as a term insurance, where we just have to pay some premium, maybe monthly or annually, and that gives me a coverage of 2 crores in case of untimely death. The other insurances can be health insurance, which we all know, medical insurances, which are very important to protect us from any kind of illness or any kind of hospitalization. Then most of the other insurances which we know about are car insurance, professional indemnity, travel insurance, and so on. Now, one of the very popular thing which has been marketed by many agents, which they themselves call as financial agents, is something what we call it as ignorance policies. Now, what are these ignorance policies? Most of the agents, they sell some kind of insurance policies which are associated with investment. And now we see that investment, when it is clubbed with any kind of insurance, is something which is really, really useless, because it does not give you adequate insurance, neither it gives you adequate percentage returns in terms of investment. So the simple one-line message can be, if you are not invested in any kind of such ignorance policies, don't enter. And if you have already unfortunately entered any such ignorance policies, please do exit. Get out of it, take out your money, and then invest in something more smartly. Now we will see what the difference we have in wealth, being wealthy and being rich. Okay, so we all know that we see rich people around, and how do we assess that they are rich? Because we see them spending. So people earn a lot of money, but they spend a lot of money, and most of the times they spend on something which is for showing off. So they spend on things like which they don't need for their day-to-day purpose, and eventually they end up saving nothing. So rich people are the ones who earn more, but they spend more and at the end save nothing. Wealthy people are the ones who may not earn that much as maybe the rich people, but they don't spend that much. They spend very smartly, they save a lot, then they create assets, and those assets is the wealth, because that wealth gives them a freedom, and that freedom is very, very important. That freedom buys them time, or that wealth buys them time, so they can do whatever they want to do in their life. So they can probably spend time with people whom they love. They have no compulsion to do something and then compromise their family time. They can learn things which they want to learn. They can spend time for whatever they wish to. So true wealth, as we say, is health, freedom, and relationships. And if you want health, freedom, and relationship as a true wealth, you need to create a lot of wealth. And that will be called as real wealth. Just earning more money will not make you free. Yeah, so I'll give an example between something which is an asset and another is a liability. Suppose I have 1,000 rupees with me. I may buy a hen, and that hen will keep on giving me eggs maybe every day. And that is an asset because it pays me every day. I'm spending, but it pays me every day. And with those same 1,000 rupees, if I buy a dog, then that is a liability because it takes away money from my pocket. So we can say in very, very simple terms that something which pays you money, something which puts money in your pocket is an asset, and something which takes away money from your pocket is a liability. Now, why do we need to understand this, asset and a liability? Because we have very, very false concepts about asset. Now, what are true assets and what are pseudo assets? So true assets are something which are easy to sell. True assets are something which we have no emotional attachment with. And the examples can be like cash, the fixed deposits, mutual fund shares, land plots, commercial buildings, gold coins, etc. Pseudo assets are the ones which are difficult to sell. There is a lot of emotional involvement, and the examples can be the own house. So suppose I'm living in my own house which is worth say 3 crores, and if I'm in need of money 10 lakhs rupees, probably that 3 crore house is useless to me because that cannot generate 10 lakhs rupees to me. So that is a pseudo asset. It will not help me in case of need, and that is what we need to understand. If I'm having a car which is say worth 50 lakh rupees, but if it is not generating any income for me, it is depreciating day by day, it is not a true asset. The furniture what we have in our houses, the gadgets which we use, the jewelry which we have, they're all not real true assets. They are pseudo assets, and this is something which we nearly need to understand before we actually generate wealth. If we put in our money in creating pseudo assets, it is spending and not generating wealth or generating assets. Now, most of us have a common concept that residential house is an asset, car is an asset, jewelry is an asset, but it is not. Because residential house, as I said, it does not give us any recurring expenses, it does not give us any steady returns, it is not liquid. As I said, if we are living in a house which is worth 3 crore and it does not give you even 10 lakhs in case of need, it is useless. Car, as we say, if I buy a car, even say 40 lakhs rupees, next day the price is going to become 35 lakhs. It is depreciating day by day. The value of that asset is depreciating, so it cannot be really called as an asset. It does not give me any recurrent income. It eventually gives recurrent expenditure for the maintenance. It does not have any liquidity. For jewelry also, the moment we buy jewelry, there is say approximately 20, sometimes even 25% making charge. So if I buy a jewelry worth 1 lakh rupees, the moment I get out of that jeweler shop, my asset value is not 1 lakh, it is 75,000. So there is immediate value erosion. Now that's why it cannot be called as an asset. Now if we want to protect that jewelry, we have to put it in some bank locker, we have to spend on that. There is no liquidity for that jewelry. So these are all pseudo assets, and eventually they become a liability. What happens is we are buying liabilities, we are not buying assets, and that is what we need to understand. So if we want to buy assets, there is something which is important concept in finance. So what is a real asset? Real asset is something which appreciates over, the value appreciates over time. It gives us some kind of a recurring income. It has got minimal recurring expenses, and it has got a good liquidity. Liquidity means we can buy and sell it very quickly, maybe on a fingertip, just like on our mobile, through some app, something like that. Now here comes the concept of financial freedom. Now we all want to be financially free. We all want to be free from the financial worries we do have in our life. So those worries can be different. Suppose I am like 40 years old right now, I have 2 kids, now I'm worried about their education. So suppose if I want to make both my kids doctors, we know that in maybe private medical college today, the fees for complete 5 years is going to be 1 crore of rupees today. Now maybe down the line, 12 years later, those fees can be 3 crores. So if I want to educate both my kids for medical graduation, I will have to spend 6 crore rupees at the end of 12, 13 years. Now, if I want to build that much amount of money, that much amount of asset, I need to start that how can I build it? I have to start investing today, and I have to plan how can I build that much amount of money. And we can be at different levels of our age and different levels of those goals. Maybe if I'm thinking about my children's marriage, if I'm thinking about my retirement funds, I need to create some corpus. I need to understand that how much money will be eventually required, and then I need to work out on that. So when we talk about financial freedom, we talk about 3 steps. They are very easy to understand. First step is the annual asset income, that is a passive income. So like I'm a doctor, I might be working in some government hospital, I might be working in some private hospital, I might have my own private nursing home. And if I'm earning, say, 2 lakh of rupees a month, then that passive income, which, and maybe my expenses, which is like my monthly expenses, say around 60-70,000 rupees, and my earnings is around 2 lakh rupees. Then the step 1 is my passive income should earn me more than my expenses. So if my monthly expense is 70,000 rupees, my passive income should generate me anything more than 70,000 rupees per month. That is step number 1. Step number 2 is my annual income should generate me more money than my actual active income. So as I said, if I'm earning 2 lakh rupees a month, my passive income should generate 2 lakh rupees a month. And that's something which is step number 2. So if I'm earning 2 lakh from my profession, and if my passive income is generating 2 lakh from my profession, I am now relatively financially free. So even if something happens, I meet with an accident, if I don't work for next 3 months, 6 months, I go with a disability, probably I am not worried, because if I am okay with my 2 lakhs income today, my passive income is generating equal amount of money even today. And the third step, which is a very important step, what we call it as the ultimate financial freedom, is even if I stop working, as I said, if somebody meets with an accident, gets permanent disability, cannot work as a doctor, because we work, if we work, we earn. If we don't work, we won't earn. And in that situation, the asset which we have created should be able to suffice us survive well with the same kind of lifestyle which we have today for next 20 years. And that is ultimate financial freedom, what we aspire for. So if we work from that background, then we will understand that what are we going to generate as a wealth or as an asset. So this is a very simple equation, though maths is something which we have probably forgotten years back, but this simple equation will make us understand that how do we generate wealth. So here W, that is wealth, is equal to P, which is the capital, principal, multiplied by 1 plus R. R is a percentage return. So percentage return is something which we are know about. So we put in money in banks, saving account, we get 2.5%. We put in money in FD, we get 5%. We put in some mutual funds, we may get some 10, 12%, something like that. So that is R, or percentage return. And N is number of years we are invested in that particular asset. So here we have to understand that the most easy thing to do is start early and stay invested. That is N, because N is exponential. N is, it is rest to N. It is not multiplied by N. So if we are invested for a higher amount of time, the wealth generation is exponentially high. We'll see how does it work. The second easy is we have to save more money. If we are earning X amount of money and we are spending Y amount of money, then that X minus Y has to be more and more. If we save more money, automatically the capital which we put in for that particular investment will be more, P will be more, W will be more. The last thing which is slightly difficult, which needs some kind of a knowledge, learning, studying, is R. R is return percentage. So we have to understand that how can we increase that percentage return. And increasing that percentage return is something slightly difficult, not too difficult though I say. Okay, now we are in a kind of a rat race of spending. Now we earn, we work hard, we earn money, we pay bills which are important, but then we spend. We spend more, we lack savings. We take large debts. Debts are loans. We take large loans. Then we have to pay a lot of EMIs. Then we still work harder. We earn much more money. We pay more bills. We pay our EMIs. Then still we spend. We lack savings. And this goes on and on and on and on. And whole our life, we are just doing that. We are taking loans. We are paying EMIs. We are spending on something. I'm not saying spending is bad, but is it with some thought? So if we are spending 5 lakhs of rupees for a Europe trip just because our colleague is doing so, or just because some Facebook friends are doing so, I think that's not great, because then those 5 lakhs is a real amount of useless spending. So this is a simple understanding. Earning, spending, and saving isn't correct. So we shouldn't be spending first and whatever remaining we should save. It should be the reverse way. We should earn, understand how much do we really need to save, and the rest amount only we should be spending. So the cycle should always be earning, saving, and spending, not the reverse way. Now we call some products as PONs, that is products of need, and some products called as POPs, that is products of prestige. Simple for us to understand. A simple, I'm just taking names for the example. A simple Vivo phone costs us 15,000 rupees, and an iPhone can cost us maybe 1,20,000 rupees. Probably both serve the same purpose, right? A car, maybe a decent car can cost us 7 lakh rupees. A luxury car can cost us 50 lakh rupees. Both serve the same purpose. So one is a product of need, another is a product of prestige. So we should stop spending on products of prestige. We should be spending on products of need only, and the rest of the money which we can put in creating more and more wealth. Now, I'm not going too much in details of taxation. Many of us know certain details, but government has given us certain ways by which we can legally save our tax. So there are different kinds of, what we can say, ways by which we can save our tax. So there are different ATC, ATCCD, 24B, ATD. So Mediclaim, home loan interest, PPFs, NPS, ELSS, a lot of ways which we can make us save tax legally. Now, I was talking about time. So let's see that this Mr. Smart started investing when he was 25 years old, and he invested 1,000 rupees a month, and he invested for 10 years till he was 35 years of age. And Mr. Delay started investment 5 years later at the age of 30 years, but then he said that, oh, he has already been investing 1,000 rupees, I will invest 2,000 rupees. And he invested 2,000 rupees a month for 5 years. Now, at the end of 10 years and 5 years for both of them, the total amount of money invested was same, 1.2 lakhs. But since Mr. Smart was investing for a longer duration of time, the amount he created was 2.63 lakhs, and the second person created only 1.75 lakhs. And this is something what we call as a power of compounding or power of time to be invested in the market. Okay, now let's come to a very interesting concept of inflation. Most of us know about this inflation because this is a pivotal concept around which the whole idea of percentage returns we are going to compare about. So what is inflation? Inflation is simple to understand. Suppose today I have 100 rupees and I can buy 1 kg sugar, 1 kilo sugar with 100 rupees. Next year, those 100 rupees will not be able to buy me 1 kg sugar because the price of sugar by next year is going to become 106. So, in a way, there is inflation which increases the price of sugar, but the other way, it decreases the value of my money. Now, we keep on hearing from our parents, our grandparents, that at our times, the sugar was 5 rupees a kilo, maybe, somebody would say 20 rupees a kilo, and today it is like 100 rupees a kilo. So, this is what inflation is, and this is how it works. So today's 100 rupees, tomorrow are not worth 100 rupees. The value depreciates. So if we keep cash, every year the value is depreciating by 6%. Now suppose we put in our money in FDs or fixed deposits. Fixed deposits are very popular kind of investment, most of the people think. Very secure kind of investment, most of the people think. Now fixed deposits give us 5% returns. So if I put in money 100 rupees today, after 1 year, bank is going to give me 105 rupees. Tax department is take away my 1.5 rupees from that. So I'm going to have 103.5 rupees in my hand. Now even that 103.5 rupees is not going to be giving me a buying capacity of buying 1 kg of sugar because the value has appreciated more than my returns. And here we are not able to beat inflation. So there is something which is called as, is your investment able to beat inflation? If it is able to beat inflation, then that is something worth. And here the concept is something called as wealth creation, wealth protection, and wealth destruction. So wealth creation is something which gives you returns, percentage returns, more than 8%. I'm talking about post-tax. Post-tax returns more than 8%. Wealth protection can give you post-tax returns somewhere between 6 to 8%. Where the value of money does not increase much, but it stays more or less the same. But products like fixed deposit, unit-linked plans, the investment and insurance plans give us less than 6% returns, and they actually erode our money. They erode the value of our money. And that is what we are talking about, wealth destruction. So we should stay away from products of wealth destruction, and a mixture of wealth protection and wealth creation is something what we desire. So how do we do it? Now we call, there's something called as GRED. Yeah, just maybe 2 minutes more. Gold, real estate, equity, and debt. These are the 4 products which give us a combination of this. Maybe age-wise the combination or the percentage distribution change, but we call something called as diversification. Diversification is we won't put all money in just one product. We can't just say that I keep on buying real estate one after the other, don't invest in gold, don't invest in equity, don't invest in any debt products, or I put all my money in equity, don't invest in other 3 products. So I have to diversify. Diversification gives you diversification of risk, diversification of liquidity, and diversification of returns. So if we see the 4 products, what we generally talk about, gold. Gold is moderate risk, moderate return, and high liquidity. Real estate is low risk, low return, low liquidity. Equity is high risk, high return, and high liquidity. And debt is low risk, low return, high liquidity. So we see that there is a lot of combination. And then if we put in our money in all these 4 kind of products, we will get diversification, and that we can even manage the risk. So what we say, there's something called as know thyself. Understand that how much time you have, time horizon for you to invest. Understand what is your age. Understand what is your risk appetite. Understand what is your goal. So is your goal, like as I said, maybe education of my child, or maybe retirement fund. Now how much is your expertise, and how much is a time you have to invest. Now expertise can be increased. What we can do is we can learn more, study more, increase our expertise. We can try to do some kind of a time management and take out 15-20 minutes of a day, which is not difficult. And then we can progress from a passive investor to an active investor to a trader if possible. Not necessarily everybody would do that, but then at least we should begin. A passive investor, we say, generates 12% returns. An active investor can generate 18% returns, and trader can generate 24% returns. So obviously, it needs more conviction, more education, more understanding as we go, and little more time as we go further. Last couple of slides. So as I was mentioning about WealthCon, WealthCon is, as I said, is a group of more than 50,000 doctors associated all over India and even abroad. And this group is a self-study group where we educate people, we make them self-reliant so that they can manage their own finances. So we have different kind of structured courses for them. So we have certain kind of educational program for passive investors, for active investors, for share trading, for futures and option trading. Now coming to the last slides of take-home message. First and the foremost thing which we need to understand is finance management, your own finance management cannot be outsourced. So that is something which is very, very important. And financial freedom will come only when we create some assets which will generate income, which will make us not necessarily work for next 20 years. So that's what I was calling about as a ultimate financial freedom. We have to identify true assets from pseudo assets and liabilities. We have to spend to create true assets. We have to save first and spend later. We have to save tax. Now, how can we do it? As I said, WealthCon, it's a kind of a movement for doctors, run by doctors, for the doctors. There are no non-doctors in this program. WealthCon will give you cognition, knowledge, courage to do this. Capital is what we need to generate. We have to start reading. We have to start studying. We need to develop patience, discipline, and faith. We have to manage our time. We have to take out some time for managing our own finances. We have to do money management. So what WealthCon gives you is development of patience, discipline, faith, and what it also gives is money management, mind management, and risk management. How can we do it? We can go on Google, search for WealthCon. We can visit the website. We can put our information and send a message. We will get a mail back from the office end, and we can join WealthCon. It is a Telegram-based group, and with this we can join different educational ways to be an investor, active investor, passive investor, or even a trader, and be financially free. Thank you very much. Sorry for exceeding my time by some minutes.
Thank you, Dr. Kedar. Nice and useful information. Thank you.
I request Dr. Sachin sir to kindly felicitate Dr. Rajesh Hire sir. I request Dr. Shiv Prasad sir to felicitate Dr. Shilpa Naik madam. I request Dr. Shilpa ma'am to felicitate Dr. Satish Shitore sir. Moving on with a scientific program, with the increasing number of delayed marriages and increasing incidence of primary infertility, the employment of in vitro fertilization techniques have skyrocketed. Methods of in vitro fertilization have advanced dramatically since the first IVF baby was born in 1978. I wish to invite Dr. Vaishali Chowdhury, an expert in IVF techniques, who will speak about creating life in IVF lab. I want to invite our chairpersons for the next session, Dr. Sanjay Kumar Tambe, Professor and Head of Department, Obstetrics and Gynecology, Dr. Savita Kamre Madam, Associate Professor, Department of Obstetrics Gynecology, and Dr. Chaya Varvi Madam, Associate Professor, Department of Pediatrics. I request our chairpersons to kindly introduce our speaker.
Dr. Vaishali Chowdhury Madam. She is an alumni of BJ Medical College, Pune. She has done her MBBS from our own institute, MD from BJ Medical College, Pune, and even she has done her PhD in subfertility under the guidance of Dr. Samre sir, ex-professor, head of the department OBGY, and Professor Dr. Ian Cook from University of Sheffield, United Kingdom. She is working as a subfertility and IVF consultant with Cloud9 Fertility Center and her own Ankur Fertility Center. And she is in subfertility and IVF since last 20 years. And the special is Dr. Vaishali Chowdhury, born in our own institute at the Sasan Hospital. Welcome, Dr. Chowdhury Madam. And when I was registrar, she was my lecturer, means assistant professor. She will deliver a talk on subfertility and in vitro fertilization.
Good afternoon, everybody. To all my respected teachers, the students, my colleagues, I bring you greetings from Cloud9 Hospital and my center. And it's a matter of great honor to be here as a faculty speaker. And I thank you, the Research Society organizing team, to giving me an opportunity to be able to share a few of my thoughts about how the journey of IVF has progressed in the last almost more than 40 years now. And just like Dr. Tambe said, yes, I was born in Sassoon Hospital and I feel very proud about that. And I did my MD, my PhD over here. And it's really, I'm grateful for giving me an opportunity. So today I'm going to talk about creating life under the microscope by in vitro fertilization. Yes, so let us start from the very beginning. Now, as you may have heard that it was 25th of July 1978 when Louis Brown was born. So this is Louis Brown, who was born to these parents, Leslie Brown and John Brown. So Leslie Brown had blocked fallopian tubes and she approached this team of doctors, that is Dr. Patrick Steptoe and Dr. Robert Edwards. Dr. Patrick Steptoe was a gynecologist and he had mastered the art of laparoscopy and doing an ovum retrieval through laparoscopy. And Dr. Robert Edwards was a physiologist working in a lab and had mastered the technique of making an embryo. So with the efforts of these two doctors, we had the birth of this super babe, Louis Brown, and this is Natalie Brown, her younger sister, who was also born by IVF 4 years later. Of course, these doctors faced their share of criticism. They were blamed by the church, by the media at that time for creating Frankenstein babies, but it was their efforts that led to the pioneering work. And we should not forget Dr. Subhash Mukhopadhyay, who is now officially labeled the father of IVF of India. Unfortunately, though he was a reproductive medicine specialist and he has done some wonderful work, and he was responsible for the birth of Durga Kanupriya Agarwal just 67 days after the birth of Louis Brown. Unfortunately, his research work was not appreciated. He was condemned. He was ridiculed. He was not allowed to present his work, which led him to so much frustration that he also committed suicide. You must have heard about him. And Durga, many must not be knowing, but she was born in the city of Pune. So, yeah, coming to any piece of art, whenever I see any good piece of art, I always feel, it is the artist who has a lot of imagination, lot of skills. Only then such a beautiful piece of art can be made. And I always used to think that I am not creative. I can't even do any painting, anything. But then I thought that God has given me the opportunity to be a part of the team that creates the biggest creation, and that is life under the microscope. So let's have a brief finding, and let's see how embryos are created. You may think it is as simple as, getting eggs out, getting sperms, and then making embryos by allowing the sperms to interact with eggs and then transfer these embryos, and then you have a baby. But no, it's not as simple as that. We have various steps. The first step is the ovarian stimulation, which is done with the help of ultrasound. If you can see the picture here, the first picture is of an ultrasound picture of an ovary on the second day of the period. So these small things are the antral follicles. These antral follicles are going to have fluid, and in that fluid is going to be an egg, the ovum. So we stimulate the woman with gonadotrophins. It has to be the right dose and the right choice. It has to be customized to the patient's requirement, and then these follicles will start growing. Our aim generally is to get something between 12 to 15 follicles, because it has been seen by various research that you get maximum success rates when you have about 12 to 15 follicles being aspirated. So by the day 10 of stimulation, the follicles become about 18-19 millimeters, and then we give the HCG trigger, HCG molecule, which causes resumption of the second meiotic division, because we want the chromosome number to be halved, and that leads to the formation of the polar body. And then is the procedure of ovum pickup, which is done under anesthesia. So you have these follicles full of fluid. So this follicular fluid is aspirated by, under anesthesia with a needle. This fluid is collected in test tubes. And then each follicular fluid will be put under the microscope to find the OCCs. OCCs are oocyte cumulus complexes. So this is how an OCC looks. And actually, this is under the microscope. Here, the embryologist is trying to screen the OCC complexes from the follicular fluid. So this is how it looks. And then they are, cleaned. They are removed from the surrounding blood so that they can be denuded. We need to denude the egg if we are planning an intracytoplasmic sperm injection. Otherwise, if it is just a routine insemination, then you can just pour the sperms around the egg without denuding. At the same time, we are processing the semen sample because we want the best looking sperms. So there's a separate andrology lab where we are processing the semen sample and getting the best quality sperms out of them. And as I said, if it is a conventional IVF where we just want about 50,000 sperms to 1 lakh sperms to be put around one egg, and then we leave it to chance, let the best sperm win. So all these sperms will be there, but the best sperm will get a chance to go inside. So this is how fertilization will take place, and we will mimic the natural method. The other way is the ICSI, which you must have seen, heard, wherein we are taking one single sperm, selecting the best sperm, and utilizing that for injecting inside the egg. So this process was first done in 1991 by Palermo and his team in Belgium. I think this is one step that has really revolutionized the process of IVF, because all those males who had very few sperms, even those with azoospermia, no sperms, have now the chance of becoming fathers with their own genetic material, their own sperms, because of this procedure. So this is done in the IVF lab. The only pros and cons, if we discuss, the cons are that the best sperm is selected by the embryologist. Of course, we have methodologies, we have very high magnifications, we have magnetic sorting and whatnot to get the best sperm out. But it is at the discretion of the embryologist. And then once this is done, let me show you a picture of the IVF lab. This is my own IVF lab. So we have various instruments. This is the micromanipulator where the ICSI is done. This is the box incubator. This is the workstation. These are all heated tables. This is an anti-vibration table. It has its own microscope. This is another benchtop incubator and a small workstation with a laminar flow to work with the media. So all these things are required because So in case we want the perfect embryos, then we need all these things. The embryo culture system, wherein we have the media which has to be properly selected with the right amino acids, right proteins, the pH has to be correct, the incubators have to be well maintained, there has to be minimum handling, air quality has to be 100%. So all these things together will lead to very good embryos. I would like to show you this video because it is definitely a good video. It has some sound. And what we are actually making is the blastocyst. So here you can see the blastocyst, which is a day 5 embryo. It has an inner cell mass, which is going to become the baby, and the trophoectoderm cells. And the final step is of hatching. So this is how we transfer the embryos. The final step is done under ultrasound guidance. There is a team of 3 people working, the embryologist who is loading the embryos in the catheter. There is the assistant doctor who is showing the probe and showing the correct plane of the uterus, and the clinician who is putting the catheter inside loaded with embryos. Usually there are 2, sometimes there is 1. So this embryo is then deposited at here. You can see these 2, these white areas is the air around the embryo. So this is how the final step of embryo transfer is performed. You don't need to give anesthesia for this. And then the last step which we leave to God is the implantation. Of course, we work hard to get a good endometrium. It is a dialogue between the embryo and the endometrium. So the embryo has to be good blastocyst stage, and the endometrium has to have 5 days of progesterone, receptivity to increase the receptivity. And if things go well, then the trophoblastic cells will embed and cause the embryo to grow. So behind every successful pregnancy, like you must have seen, is a good IVF lab, a good stimulation protocol, effective gonadotrophins, a team of fertility clinician, counselor, embryologist, andrologist, the IVF nurse, and of course a checklist. I don't have to tell anybody what is the importance of checklist in the field of medicine, but there is a lot of work that goes on in the lab even before, one day before. There is a daily equipment login, a lot of QA, QC to be done, media preparation, very correct labeling, The media that we are using, that you can see here, it is taken out from the fridge. We cannot use that just directly. It has to have the correct pH. For that, it has to have the correct amount of CO2. So a lot of efforts go in the documentation and actually being ready to get these embryos. The most frequent question that is asked to me is, what is the success rate, doctor? And if you read papers, or if you read websites, where you will find some people will say 40%, some people will say 60%, and some people will say 80%. So how do we measure the success? Is it a positive beta HCG? Is it a gestational sac on the ultrasound, or is it the fetal cardiac activity on ultrasound? Or a live birth, take-home baby is what everybody is interested in. So I have put up a graph that was presented in 2018 journal by the HFEA, which is the highest authority. So they have been tracking these success rates, and this is showing the birth rate per embryo transferred. So if you transfer one embryo, then the live birth that you will get has progressed in 1991 from 9% to about 32%. So if I put one embryo, one good blastocyst, I will get a take-home baby rate of 32%. What happens in my clinic? Very often we are putting 2 embryos because we have to be cost effective many times. So when I have women less than 35 years and I put 2 embryos, our clinical pregnancy rate, which means embryos seen with cardiac activity, on the ultrasound is 61%, and take-home baby rate is somewhere around 48%. And for women whom I put 1, the clinical pregnancy is 46%, take-home baby rate is 34%. Because IVF patients have their own share of miscarriages, second trimester abortions, and so on. Now the question is that, are we overusing IVF? Because you've seen the IVF success rates getting better and better. We have seen thousands of clinics and centers mushrooming. So I sometimes wonder that nowadays the awareness has increased, and are we as fertility consultants responsible for taking this art of making babies from the bedrooms into the IVF lab? And if we are indirectly responsible, I'm not happy about it. Because what we see from the graph, you see now in today's world, we have almost more than 9 million babies that are born due to IVF. And now this data, unfortunately, has not taken in consideration the Indian data. This paper that I took out this data from did not have the Indian data. So if we calculate the Indian babies, imagine how many there would be. So many patients are using IVF. Why? Are we overusing it? I need to inform you that now the indications have also changed. Initially, we were using only for blocked tubes. Blocked tubes, no chance of natural pregnancy, do IVF. But now there are all these indications that we are using. We'll come one to one. So what has helped to increase the success rates? We all know necessity is the mother of invention, right? So this step of discovery of vitrification, that means rapid freezing, has been the key changer which has led us to open a Pandora box of so many other patients requiring IVF. So what happened? How this came up? In the initial days of IVF, when women were taking a lot of these gonadotropins, they were producing lots of follicles. Each follicle had granulosa cells. All these granulosa cells were producing estradiol. So the estradiol hormones were rising. By the time of trigger, there were 3,000, 4,000. And then we used to give them a trigger with HCG. Now this HCG molecule used to lead to a condition called as ovarian hyperstimulation syndrome. This is a life-threatening complication. Because of high estradiol and the trigger by the HCG molecule, there is huge increase in the capillary permeability that leads to lot of shift of fluid from the intravascular compartment to the peritoneal, to the pleural, to the pericardial, and sometimes it used to be life-threatening because of shock, thromboembolic events, and so on. And HCG was the culprit. So they thought of, why not think of something else, because they realized that there was a group of women who didn't have their own follicles, and they were taking some donor's follicles. So they themselves were not taking injections. Some other woman was taking injections. Some other woman was getting her pickup done. And then these women who were not taking injections had better success rates, better implantation rates, and they never had OHSS. So the scientists realized, the doctors realized that if you do a fresh embryo transfer immediately after the pickup when the estradiols are high, and if you give an HCG trigger, you are going to cause OHSS. So let's divide this into two parts. First, let us freeze the embryos. So initially also we were doing freezing, but we were doing in a slow method. When you do slow method freezing, what happens? The temperature gradually goes down to minus 196. When it is going down, it's fine. But when you thaw this embryo, the water that had crystallized during freezing, the water became ice, and that ice was breaking during thawing. And those crystals were causing damage to the organelles, the intracellular organelles. So the embryo after thawing was not good enough. So we were not getting good results with freezing and thawing. So came vitrification, which was a flash freezing. So there was no chance given for ice formation. There were a lot of cryoprotectants, which was covered, the embryo was covered with that, and that cryoprotectant was immediately within a second dipped at minus 196 degrees. So the whole embryo became solidified, it became vitrified. And then later on, because of the cryoprotectants, it was never harmed. So when we thaw, we get perfect, we get almost 90-95% recovery. So when we thaw the embryo, for example, I'm showing a video here where she's thawing. There are these cans. In those cans, now she was reading a paper. There is a very detailed description, which number can, which canister, which color straw, how many embryos. And there will be a label written. So she's removing that straw from inside. It is a very tiny straw. This is going to have the embryos. And there is name written on that. She's going to put it under the microscope and then confirm and get those embryos out. So what then started happening, that all those women who had high estradiol started doing their IVF in two ways, in two steps. First, you stimulate the ovaries, estradiol बढ़ रहा है, no problem, let it increase, take out the eggs, make the embryos and vitrify those embryos. And then in the next month, you do the embryo transfer when the estradiol levels have come back to normal. So now I have so many patients where the first baby was born. Like for example, this baby is born, this is not my patient, but I have a patient like this, who was born 3 years back, and that time we had frozen embryos for her, and those embryos were kept frozen, and now we thawed that batch, and now she again delivered, and she's got another baby. So technically they are twins because they were conceived on the same day, but they were born 3 years apart. So this is now what is happening with freezing, and so we have so many indications. There is something called as social freezing, where I don't want a pregnancy now, so let me freeze my eggs, because now we are freezing eggs, we are freezing ovarian tissue, we are freezing semen testicular tissue, semen sample. So those patients who are not ready for transfer, for all those we have freezing. And we have, you won't believe, but we have, every year we have one new can where we have to store embryos. So I think by the time I retire, there are going to be 2 rooms full of cans and embryos and eggs. And I don't know how I'm going to hand over. Anyway, so if you ask any woman, any doctor, any fertility specialist, which factor is the one that decides the success rates, it is the age of the women. Why? Because the number of eggs starts decreasing, and especially for people from our field, because we are educating till the age of 29, 30, routinely we are educating. We have not settled down. So your body doesn't know that you have an exam to give. Your body is going to decrease the number of eggs. And when the woman comes in a late stage, her mitochondria are very sensitive to aging. They do not provide the energy required for the meiosis, for the divisions. And so we see that older women don't produce very competent embryos. Hence their success rates are also lesser. And even more bad news. There was this study which was done between European women and Indian women, and I was, I wouldn't say part of the study, but I was working in that institute when this study was being done. And the Indian women's ovaries are aging 6 years earlier than the women from the Europe. Now, why this is happening, we don't know. Maybe our grandmothers and mothers were getting married early and producing their share of children, so it never, we never realized this, but now we are realizing this. So for older women, very often we do something called as embryo pooling. So we do not 1 cycle, but 2 cycles, 3 cycles, and we get embryos we make embryos in each cycle, and we freeze them, and then one fine day we transfer the best ones. But this can be draining, it needs a lot of willpower and a lot of money also. Or the option remains, as I said, of donor eggs. There are women who are perimenopausal, more than 40 years old, sometimes no eggs. Husband has good sperms. So what do? We get a donor and we stimulate her, get her eggs out, make the embryos and transfer back to this lady, older lady. Of course, there are a lot of steps. There is recruitment and legalities and screening and investigations, lot that goes. Also for PCOD. PCOD patients, same problem. Too many follicles, too much estradiol, need to do IVF because their ovaries are stubborn. Sometimes they respond, sometimes they just don't respond, sometimes they overshoot. So for them, segmented IVF necessary. Social problems, as I was discussing. Girls are ready for education, they are having a high profile career, they are even ready for marriage. But pregnancy, no. Because she cannot balance both the things. And so they go for social egg freezing. But we have to do a lot of counseling. Otherwise, she will come back for getting her baby when she becomes this old. So she's supposed to be a grandmother. We can't tell her now you come and become a mother. So a lot of counseling needs to be done. As I say, with a lot of power comes a lot of responsibility. So in azoospermia cases, previously azoospermia, the man used to think nothing can be done. Even doctors used to think abhi to wiki donor ke paas jana padega. But now no. We are aspirating sperms from the testes, from the epididymis, and we are using them and making embryos with those sperms. And believe me, it's very satisfying and these embryos are really good. Also, there's a new field that's coming up which is called oncofertility. See, because what happens, especially the young women who have cancer diagnosed and they are taking chemotherapy. So the stronger the chemotherapeutic agent, the more damage it is going to do to the ovaries. So these poor things come back with lost follicles. They come back, they survive well. Their chemotherapy they have done well. And believe me, the ones who are survivors have a terrific will of becoming parents. But when they come back, they realize their eggs are gone. So for these women, we do a quick cycle, quick freezing, and then she goes for her chemotherapy. So her ovaries are saved. And then she can come back and claim and make babies out of that. Surrogacy. If you don't have a uterus, like MRK syndrome, or you have a very badly damaged uterus, like Asherman's, what do? You have good eggs, your husband has good sperms. You make embryos, you put it into a surrogate. There are a lot of myths about this surrogacy, you know, especially the movies show all rubbish. They think that the surrogate is the biological mother. No, the surrogate is only giving her uterus. The genetic mother is the one who's giving the eggs. So the wife will give her eggs, we do an IVF. We take out her eggs, we make an embryo. She is just providing the uterus, you know. In the OT, we are inseminating this. Then a surrogate is also supposed to breastfeed baby. No, we prefer that she does not breastfeed baby. Her job is done, she is supposed to go. There's a myth that a surrogate will not give up the child, like it is shown in the movies. That cannot be, because there is a contract. And I have done a lot of surrogacies. Surrogates are interested in getting their money and going away. They have nothing to do, they don't even want to see the baby. This is an interesting field. You have a patient with, let's say, a baby who has thalassemia major, or the wife and husband both are thalassemia minor. And now they want to have a baby. They don't want to have a baby which will end up becoming a major, or get an abortion done, or get an amniocentesis done. So we are taking out the trophoectoderm cells and we are doing their karyotypes. We are genetically testing to find if there are affected embryos, we'll discard. And the best looking embryos. So are we doing designer babies? No, this is done only for medical conditions. We don't do blue eyes, green eyes, long hair, curly hair. No, that is not done. There is a legal contract and we have to prove what we are doing. There is a lot of paperwork. Another question, do IVF babies have more incidence of congenital defects? So you will find a lot of papers. Some papers will do one thing. They will compare babies born out of IVF with babies born who have not done IVF. I think that's not the right thing to do, because people who come for IVF are the ones who are 35, 38, 40, male factors, hypertension, diabetes. So how can that group is different? The one who is conceiving naturally, that group is different. So you cannot compare. So when you read these papers, you have to be very, very vigilant and understand. The Indian paper, you will find that really there is not much higher incidence. Yes, 1.8% was generally what was found, and I believe it is because of the class of patient that we are dealing with. Now the role of fertility counselor, you cannot have an IVF center without a fertility counselor. There is a lot of things to explain patients. We have such funny stories coming up in our, there are people who come with say, my husband has no sperms, please can you take my brother-in-law's sperms. That is not done. We cannot do that. We have to counsel. Before the cycle starts, we have to tell them the success rates. We have to show them the graphs. And of course, when the cycle fails. When the cycle fails, she has to understand she's a loved woman, she's appreciated, even when she's not able to conceive. So it needs a lot of, counseling. If we talk about complications of IVF, as I have discussed, OHSS, twins and triplets, yes. So we are also now shifting a lot to single embryo transfer. Premature deliveries because of twins and multiple pregnancies, more incidence of LSCS because they are again a high group of high-risk patients with diabetes and PIH and elderly women, twins, all these indications. Frozen embryo babies have been found to be much heavier. Why? We don't know. But frozen embryo babies have been found to be heavier. But we have a long way to go, because you see the frozen embryo baby, the first batch of frozen embryo baby, let's see, is about 30 years old. We still have to see the long-term complications, because you're putting them at minus 196 degrees and you're coming out on 37 degrees. And so with a pinch of salt, the mental agony, if the case fails, is tremendous. So where are we today? We are dealing with a success rate, as we have already discussed. We don't have more than 50% take-home baby rate. We need to work on that. Healthy mother, there are their own complications which we need to address. Cost, this is the most pinching thing. We need newer innovations, we need milder stimulations. Healthy babies, yes, that is the aim. But preterm incidence is more, anomalies incidence is also slightly more, LSCS incidence is more. So we do have a few complications with the babies. To bring down the cost, do IVF only when indicated. Not to do routinely for unexplained infertility or mild male factor. Milder stimulations work better. Pharma companies to cap the prices, miniaturization and automation of the IVF lab, e-counseling so that the patient doesn't miss the work, legally mandated insurance coverage for fertility treatment which is not there, and government hospital, I don't know when will that happen, to provide subsidized IVF. So now just 2 more slides. Let's also talk about the business of IVF, because I believe that the advertising and the marketing travels faster than science and of course faster than ethics. So a lot of add-on treatments will be, advertised. The false fake claims will be done. So many things are to be, to be avoided and to be very careful about. So we as a fraternity need to understand, with great power comes great responsibility. Of course, the new upcoming ART law, which has been passed on 25th December 2021, will definitely bring a lot of welcome changes, and it will cause more regulation, more licensing. People will be more accountable with the national board establishment. We are really looking forward to that. Now just 2 slides about the future of IVF. What else are we doing in IVF? See, as I said, aging mothers have very poor mitochondria which make the embryos weak, and there are certain DNA problems, certain diseases which are passed from the mother to the baby from the mitochondrial DNA, though it contributes only to 0.1%. So what has been done for these patients? 3% IVF. You take a mother's egg, you take the father's sperm, you make an embryo. You take the pronucleus that is formed, you take it out and you put it into a younger patient's embryo where her nucleus has been removed. So it's like changing the laptop battery. So you give a new energy, but the hard drive information is same. So this is how 3-parent IVF is done. And now also there is quite a success being achieved with creation of sperms in the lab. So all the men sitting here, beware, we are not going to need you. So this Eve says, I don't need you, I have my stem cells and I can get sperms made out of this. So lots to look forward to, lots to learn, and we have seen an amazing journey, and I am once again very thankful to you for giving me a patient listening, because it's our job to keep hopes alive to all those infertile couples, because they don't fall in the category of sick patients, unfortunately. That's why government is also not interested in infertility. Government is of course interested in more important programs like family planning. But these patients are suffering not only physical problems, but mental stigma of infertility. So we have to keep the hopes alive and we have to do ethical work. I thank once again for your patient listening, and thank you chairpersons for giving me an opportunity. Thank you.
To see how a life can be created into the lab. Thank you so much.
Thank you, ma'am. I now request the chairpersons to kindly felicitate Dr. Vaishali Chaudhary, ma'am. I request Dr. Bhumika. I request Dr. Bhumika to felicitate Dr. Tambe sir. I request Dr. Rashmi to felicitate Dr. Kame madam. Continuing with our program, moving on to the next session. Cancer is one of the leading causes of morbidity and mortality in developed countries. Complex clinical decisions about treatment of oncological patients are largely guided by imaging findings. Most radiological procedures map the anatomy and morphology of the tumors with little or no information about their metabolism. PET scan proves valuable in providing important qualitative and quantitative metabolic information. To give us further knowledge on this, I will invite Dr. Shrikant Sola on stage. I wish to invite our chairpersons, Dr. Shefali Pawar Madam, Professor and Head, Radiology Department, Dr. Lata Bhoir Madam, Associate Professor, Department of General Surgery, and Dr. Ibrahim Ansari, Associate Professor, Department of Radiology, to kindly come up on stage and introduce our speaker for today.
Good afternoon, everyone. After a wonderful session on creating life, we move to another arena where we will discuss how to improve the quality of life of patients with cancer. And for this, we have to do the investigation called PET. Today, to discuss on PET, to enlighten us, we have an eminent speaker, Dr. Shrikant Solaph. He has completed his MD in medicine from Bhopal University, and then he has done his courses in nuclear medicine from Mumbai University. He has been practicing as a consultant for the past 22 years. And he has also done his specialization in nuclear cardiology at Jaslok Hospital. He has about 40 research papers to his credit. And he has the credit of having established the first PET-CT in Pune in 2007. Over to you, sir.
Thank you. Thank you very much, ma'am. It's indeed a privilege to be here, and it brightens my day to be honored with, a presentation at BJ Medical College. So how does this tool differ from the one which I use? I consider gamma camera as a scaled up tool of a stethoscope. As a second year student, you are taught that a stethoscope is used in listening to the cardiac murmurs. For instance, a systolic murmur signifies aortic stenosis or mitral regurgitation. As you mature, you learn to differentiate between a pansystolic murmur of mitral stenosis from mid-systolic murmur of aortic stenosis, of mitral regurgitation, sorry. Similarly, as you mature further, you know that not all systolic murmurs are because of valvular heart disease. There is something called as a hemic murmur, and that's important to also know how to distinguish a murmur from a bruit. So to be a good teacher, you should have a good student, and to have a good student, you must be a good teacher. So for instance, if you were going to, as a teacher, you were supposed to select a student for an inter-school competition. So you will select a child who is skilled at debates. You will select a different child for a sports competition. Similarly, yet another child for a singing competition. When you are dealing with nuclear medicine, you have to understand that you are not dealing with structural imaging. Your imaging is directed towards different organ functions. And to understand this, you must know the properties of various radiopharmaceutical molecules, and so that you can adequately apply it in day-to-day practice. So when you are, as a teacher, when you are selecting a student for an inter-school competition, you are not bothered about what are the skills of your competitors. You are more bothered about what your students are capable of performing. So these are the molecules which are not available with us. For instance, fluorocholine, fluorohydroxyephedrine, etc., etc. But you have to focus on what we have with us. So fluorine 18 is a typical workhorse in nuclear medicine, which is labeled with fluorodeoxyglucose for most of the studies. But you have yet other molecules such as fluoroethyl tyrosine for tumor imaging of the brain. You have fluoride. You have PSMA, which is called as prostate-specific membrane antigen for evaluation of prostate malignancy. You have somatostatin receptor analog, and you also have a DOPA scan. You have yet another molecule by the name of gallium-68, which can be labeled with so many other agents. For me, PET-CT and gamma camera are sort of two inseparable tools of nuclear medicine, and you have to judiciously apply each one in a given clinical situation. Coming to the first case, an elderly gentleman who had been operated in the past for supposedly Crohn's disease. He underwent resection of the colon because they thought, and the diarrhea would not stop. So until he consulted another gastroenterologist who said this is not a local colonic diarrhea, this is a secretory diarrhea. So, with having made the diagnosis of a secretory diarrhea at the patient's bedside, he did not order for an FDG PET scan. He said, straight away go ahead and get a somatostatin receptor PET scan, because this was the colonoscopy, which was unremarkable. And this is the somatostatin receptor PET scan. You can see that's physiologic uptake in the spleen, and there's a hot dot here corresponding to the nodule in the right lung lower lobe, which was the pulmonary carcinoid. So correct clinical judgment gives you correct choice of isotope. This could have been falsely negative had we done a FDG PET scan on this patient. So that's the name of the molecule. And these are the situations where it is useful. Carcinoid tumor, insulinomas, medullary carcinoma of thyroid, etc., etc. That's our publication in the Journal of Neuroendocrinology on value of functional imaging in neuroendocrine tumor. This surgeon called me one after having done surgery for a superficially growing sigmoid tumor. He said, I cannot believe that this patient has developed a fracture within 1 month of supposedly very superficial tumor. And it was a very small tumor, and I cannot believe that this has happened. So will you please do a PET scan? So pre-operatively, the patient had an ultrasound, which was normal. He had an X-ray chest, which was normal. And 1 month down the line, we did a PET scan. Look at this. There are hot spots all over. That's in the liver. And something is here, which was missed on the plain X-ray because it was a neoplasm behind the patient's heart. Naturally, it was going to be missed. So synchronous primary malignancy and FDG PET, had a PET scan been done upfront 1 month earlier, perhaps both the malignancies could have been diagnosed, and this was operated upon, and that's the histopathology. And that's our publication in the World Journal of Nuclear Medicine on value of PET in occult primary. This is an extremely intriguing case. The physicians calls me saying that this patient has been in and out of the hospital for 2 months. He's been running fever, he's breathless, he's multiple symptoms, all possible investigations are negative. We just find a lung nodule, and can you help us? And I said, well, you send the patient because, there are advantages of doing a PET scan, there are limitations, so let's try our luck. And this was the nodule which I was talking about, he was referring to. We did a whole body PET scan. Look at that. Everything is sort of physiologic. The lung nodule, which was here, is completely cold on an FDG scan. Now, cold lung nodule could be because of carcinoid. It could be a fibrotic tissue. Question is, are we missing some malignancy? Most of the times, the patient's creatinine was sort of borderline. We could not do contrast. Most of the times, we avoid contrast. So I asked my technologist, let's get an MRI of the liver because, a non-contrast can miss an MRI lesion and can miss a lesion of the liver, and an MRI is a more sensitive tool. So we asked, my technologist comes back and says, sir, the patient is quite breathless. We cannot take him for MRI. He's on oxygen. So we shifted him back to the hospital, and I called the physician. I said, have you done the patient's echocardiogram? He said, yes, it's normal. I said, for God's sake, go back to the cardiologist, ask for a repeat echo, and get a D-dimer. So he said, what are you suspecting? I said, I've already told you what I'm suspecting. In the evening, he calls me saying the echocardiography does show mild pulmonary hypertension, and then he tells me that the D-dimer level is 1,000. I said, please send the patient tomorrow morning for a VQ scan. And that's what he had. He had ventilation perfusion mismatch, and this was a pulmonary infarction, a subsegmental pulmonary infarction, which was sort of being, that was the reason the patient had breathlessness. So maximize your clinical skills. These are just the tools which will help you coming closer to the diagnosis. Tennis is thyroglobulin elevated negative iodine scan. So what happens in a patient who has been operated for carcinoma of thyroid? You resect the tumor. Having done that, you want to make the patient's body free of hydrogen secreting tissue. So the remaining tissue in the neck which is there need not necessarily be malignant, but you want to make the patient's body free of thyroglobulin secreting tissue. The reason is thyroglobulin acts as a surveillance marker on a follow-up. So you don't need to do iodine scan again and again. What happens in a patient like this, what is called as thyroglobulin elevated negative iodine scan? So for instance here, the patient had been operated and this was ablated. After ablation, the scan became negative and the patient complained of backache. Initial bone scan was normal. The patient continued to have backache. We repeated the scan and it showed 2 hot spots. So we said, these are probably malignant. This is probably malignant tumor spread from the CA thyroid. And the iodine scan was still negative. So we'll do a FDG PET scan. And on FDG PET scan, which was done in a month's time or so, you can see there's a hot spot here in the skull. There are multiple areas elsewhere. So once you know that this is a metastatic thyroid cancer, which is not concentrating iodine, how else will you treat it? You sort of feel helpless. So there is one new tool with us now, what is called as a peptide receptor radionuclide therapy. And for that, you must combine an FDG scan with what is called as a DOTA scan or a somatostatin receptor PET scan. So here is the FDG scan, and that's the DOTA scan, which shows uptake in all these regions. So this can be labeled with what is called as lutetium. So it's a beta-emitting isotope, which is when labeled with somatostatin, goes and localizes in the metastatic deposits. Of course, it remains a palliative treatment. History of carcinoma of breast surgery in the past for which she was treated, and recent episodes of hypoglycemia. The CT scan report was quite intelligent. It said that there was some well-defined lesion in the head of pancreas, likely insulin. So they suspected this on CT. Question is, are we chemically correct when we say that this, or is this something, surprise on table? So to come closer to the diagnosis, you can offer either, there are two types of scans you can offer. One is somatostatin receptor PET scan, because as I said, FDG PET scans are going to be falsely negative in neuroendocrine tumors, which includes insulinomas. So, and the somatostatin receptor PET scan shows intense somatostatin receptor activity, and a fusion PET MR scan further delineates the tissue. What happens if you land up with a negative somatostatin receptor PET scan? You have yet another molecule, what is called as an GLP-1, glucagon-like peptide 1 receptor PET scan, for the detection of, for instance, this patient who had negative DOTA scan but a positive exentin scan. This is a medical student, medico, who had developed paraparesis because of this compressive myelopathy. It was decompressed, and the surgery, the histopathology was metastasis of carcinoma of thyroid. Very unfortunately, this patient had a thyroid nodule excised earlier on, 5 years ago, which was reported to be benign. And the patient was referred to me for a PET scan. And I said, PET scan is not the test of choice in this patient, because here you have a pathological, deposit of iodine carcinoma of thyroid. What you need to demonstrate is whether these deposits are concentrating iodine, which most of them they will. Follicular carcinomas, papillary carcinomas, well-differentiated carcinomas will concentrate iodine. So you have a scope of treating them with high-dose radioactive iodine ablation. So that's why we said FDG not indicated, and look at that. Almost everywhere there are skeletal metastasis on an iodine scan. One important PG question for exams is, what type of malignancies can be detected on imaging where histopathology becomes redundant? You don't need to do it. This is one of them, because it's concentrating iodine. It has to be carcinoma of thyroid metastasis. So this is after treatment. You can see all these deposits have disappeared, have vanished, and 2 years down the line, once again, he remains free of disease. So carcinoma of thyroid, first line of treatment, iodine scan. In case of tennis, that is when iodine is negative, you choose FDG scan. Take a look at this. Hip pain, inability to walk. When it goes to the orthopedic surgeon says this is pathological fracture, occult primary needs to be detected. We did a FDG PET scan, virtually normal spine. This is some fracture-related inflammation, but we couldn't detect any occult primary. And there were multiple osteolytic lesions in the pelvic bones. Can you see that? What's your diagnosis? Multiple myeloma, that's what was prompted. So we said, this lady, when you say multiple myeloma, it's sort of helplessness. You're, going ahead with palliative or, So I said, let us also do metabolic workup for this patient and ask for calcium, phosphorus, alkaline phosphatase. The PTH value was 2000. Sesame B, parathyroid scan, or a technetium thallium subtraction scan. It's a very simple principle. Technetium goes to the thyroid, sesame B or thallium goes to thyroid and parathyroid. All you need to do is inject one after another without moving the patient, ask the computer to subtract the images, and there were 2 adenomas, one here and one here, further confirmed on SPECT CT. And this, you have to know that these patients can present to an orthopedic, they can present to a gastroenterologist, they can present to a psychiatrist, they can go to an intensivist for all these reasons: renal stones, urologists, abdominal groans, psychic moans, etc., etc. Look at this lady. She couldn't walk pre-operative without support, and post-operatively she's independent. So it's such a gratifying tool. Occult primary evaluation. This lady had a mass in the scalp. This patient had a big mass in the scalp, and there was something in the pelvis also. So this was the working diagnosis on clinical examination. An FDG PET scan was requested. This was the MRI impression which said suspected osteosarcoma and large osteolytic lesion on FDG PET scan. And there was a hypodense, weakly metabolic nodule in the thyroid gland. So we asked for a thyroglobulin and we asked for FNAC, and it did turn out to be papillary carcinoma of thyroid. So it's a very useful tool for detection of occult primary. So overcoming, this was a referral bias in the previous case also, in this case also, there was and this is yet another case of referral bias. Patient comes with fracture and a shadow on a chest X-ray where they thought that this is malignancy of the lung. FDG PET scan shows completely cold mass, and the patient had recurrent vomiting. So on a full stomach image, you can see here, there is some weakly metabolic. There is hardly any uptake on FDG scan in that pylorus, which is thickened up and distended stomach. So we said we have a new tool, what is called as a FAPI, fibrinogen activation protein inhibitor. It's a new molecule. We said, let's try this. We talked with our ethics committee people, and you can see here, FAPI shows intense uptake in the pylorus, which is otherwise cold on, that's FAPI and that's FDG, which is otherwise cold on FDG scan. So we said that this is suspicious for malignancy, and the histopathology, of course, was signet ring cell carcinoma. When biochemical parameters fail a nuclear medicine physician, such as in this patient who was having long-standing diabetes, she had abdominal pain and some weight loss, the blood sugar was 500. When you do an FDG PET scan, the dictum is you have to have a blood sugar less than 200. We give a leeway of about another 50 milligram per deciliter. So less than 250, we can still perform it. But if it's high, we have to either ask the patient to return. This patient was from outstation. You are always worried about patient's management. So we offered a FAPI scan with a caveat that in case FAPI fails, we may call the patient for a complementary FDG on another day. And look at that. This was a real surprise for us. Both the kidneys were showing intense uptake on FAPI scan, and that's intense uptake on FAPI scan, which is unusual. The MRI of the kidneys, which was again complementary, showed edematous kidneys. A DMSA scan is a gold standard for detection of renal scars and pyelonephritis. Look at this. Both the kidneys are showing irregular contour. Both the kidneys are showing irregular contour, and there are cortical-based multiple cold areas. So this was a case of bilateral pyelonephritis. And that's a publication in Asian Journal of Nuclear Medicine on value of PET in pyelonephritis. Yet another patient, the physician who referred me was really upset with me, this patient. Fever running for 2 weeks or so. Every other workup was normal. There was some circumcision done in the past, and they thought that this was a urinary occult infection. So we do a PET scan, and it was rock normal, other than tiny nodules in the region of thyroid gland. So I asked the physician whether the patient's thyroid functions have been done or not. The patient has been having fever. And so the physician was a little upset. You have no business of thyroid. I said, madam, we are in the interest of the patient. So anyway, next day the thyroid function tests were revealed, and the T3, T4 were high. The TSH was suppressed. I said, likely to be thyroiditis. We repeated the thyroid scan, and it shows clear evidence of subacute thyroiditis, important cause of fever. This is a full-length publication in the American Journal, Pyrexia of unknown origin, value of PET scan. Many a times the correlative imaging modalities are not conclusive. For instance, in this patient, young man operated for renal cell carcinoma. Ultrasound on follow-up showed some suspicious lesions in the liver, question mark hemangioma. However, in view of history of renal cell carcinoma, possibility of metastasis cannot be ruled out. That's what it was. This was, and an FDG PET scan, the hypodense lesion is completely cold. So it's unlikely to be metastasis. But we said we have to come to a diagnosis. So we offered what is called as a RBC blood pool scan, and the same area brights up vividly on a technetium blood pool scan, RBC tag scan. That's a gamma camera scan. It shows cavernous hepatic hemangioma. When you are logistically challenged, for instance, a patient has missed his bus in the morning and lands up at 12 o'clock. FDG has a half-life of 110 minutes. I have no isotope with me. What will I do? For instance, in this patient comes with a history of malignancy in the past, has body ache. FDG is no more with us. We said, well, we'll attempt a FAPI scan If inconclusive, we'll offer a FDG PET scan, but luckily we didn't have to do that. You can see almost entire skeleton is studded with, liver is studded with metastasis. So choosing the right molecule for the right patient. For instance, here, this patient has carcinoma. This is the same patient. FDG PET scan is falsely negative because carcinoma prostate is a slow proliferating tumor and is likely to give a false negative result on carcinoma on an FDG scan. Carcinoma prostate shows intense localization in all the metastatic spots. The books tell us that if a patient of carcinoma prostate has a PSA value of less than 10 or 20, it's unlikely to have spread to the bones. Having done PSMA PET scan over a period of last 8 or 9 years now, we have a list of cases to defy the teaching. This is an extraprostatic. That patient has a PSA of 16, extraprostatic extension, pelvic nodes, and multiple skeletal metastasis. PSA is not very high. Look at that. This child with, myoclonus, opsoclonus syndrome, the pediatrician said we want to do an MIBG scan. MIBG has logistic challenge because you need to get it, procure it separately, it's expensive. We said we'll offer you a DOTA scan, and in case we are falsely negative, we'll do a complementary MIBG. Luckily for us, look at that. This is once again the somatostatin receptor PET scan, kidneys, and look at that, right bang in the center. That's the occult neuroblastoma picked up on somatostatin PET scan. Knowledge is piling up of facts and data. Wisdom lies in simplifying those. Thank you very much for your time. That's a tiny memoir of Spec Lab, last man in the queue, life in the midst of nowhere. This is a flower from our garden. It's called as Legastromia lancastri. This is impatiens, that's bird of paradise or heliconia. And I would like to congratulate, the reason for showing you this comes soon. I would like to congratulate the members of staff of Sassoon Hospital and BJ Medical College for the new PET scan that you're soon going to have. And congratulations. And that's the phrase I read on the streets of Seattle. A flower does not think of competing with the flower next to it. It just blooms. Thank you very much for the invitation and the time.
Thank you, sir. That was a wonderful compilation of very rare and interesting cases. You have always been a help to us, or our patients actually.
Thank you.
Thank you, sir, very much.
Thank you very much.
I request Dr. Pradnya Bhambire to kindly felicitate Dr. Shefali Pawar, Madam. I request Dr. Rashmi Zavanzar to kindly felicitate Dr. Lata Bhoir, Madam. I request Dr. Rohit Wagmare to kindly felicitate Dr. Ibrahim Ansari, sir. We have a small announcement for everybody present here. Kindly submit your feedback forms at the registration counter for collection of your MMC points. Thank you. Kindly note that general body meeting will be held after this session. So the life members are requested to be seated after this session. Moving on with our program. From the moment we are born, every injury to the skin has a potential to form a scar, many of which can impair form or function. Yet, effectively promoting scarless wound healing remains an elusive goal. Many advances have occurred over the recent years, some of which have translated scientific findings from bench to bedside. To guide us to achieve this elusive goal, I would like to call upon Dr. Dhanashri Bhide, a dermatologist, and Dr. Shaunak Sule, a plastic surgeon, for giving their point of view on recent advances in wound management. Our chairpersons for this session are Dr. Hari Shumratskar, sir, Associate Professor, Department of General Surgery, Dr. Nikhil Panse, sir, Associate Professor, Department of Plastic Surgery, and Dr. Vasudha Belgaonkar, Madam, Associate Professor, Department of Dermatology. I request the chairpersons to kindly introduce our speakers.
Very good afternoon to all of you. And our first speaker today is Dr. Dhanashri Bhide, Madam. She, I would like to say, is a one-woman army, and suffice it that she is a great inspiration and mentor for all of us. She is great. She has achieved a lot of things, and she is an all-rounder. Her interests range from clinical dermatology, dermatosurgery, cosmetic dermatology. You can say it all. So today she's here to share with us her perspective, that is, a dermatologist's perspective on the management of wounds. Over to you, Dhanashri, ma'am.
Good afternoon, dear friends and colleagues, respected chairpersons, seniors, and teachers. Today, I will be talking on this topic of recent advances in wound management, a dermatologist's perspective. And at the outset, I would like to thank the entire team of Research Society and my friends, Dr. Pradnya Bhalerav and Dr. Vasudha Belgaonkar, for giving me this opportunity to present my views on this particular topic. So, as a dermatologist, how our mindset is different from a plastic surgeon. We try to be minimally invasive, and as far as possible, we try to do the procedures on OPD basis. We don't like to admit our patients, and most of the times we are more comfortable with local anesthesia rather than putting the patient under general anesthesia. So I will be mainly talking about the methods using different types of platelet concentrates, then tissue grafts, and a very age-old but quite effective technique of honey and ghee in wound healing. So these are the various methods which I will be discussing, followed by a short video presentation. And most of the times, the commonest conditions or the indications for which we have to use these methods is leprosy and chronic non-healing ulcers of various etiologies. They may be venous or arterial ulcers, surgical or post-traumatic, and often we have to deal with patients suffering from pyoderma gangrenosum. So coming to the various methods using platelet concentrates. So when you look at the literature and try to see the different protocols and how you will go about these platelet concentrates, you will find that there is lack of standard protocols and agreed definition as to what is platelet-rich plasma. Then the high-level evidence for all these articles, there is a lot of paucity of this high-level evidence, and the inconsistent final composition. So it is actually operator variable, and that is why there are a lot of problems when you are dealing with these particular methods. So more studies are required in order to standardize the protocols. So what do you do? Like in spite of all this, we find that these are very effective and useful adjuvants to the standard methods of treatment of various non-healing chronic ulcers, and therefore we all must practice these techniques. So the various methods that we do practice in our OPD are using first generation platelet concentrates. Sometimes we use a platelet poor plasma as a gel and which is used as a biofiller, and we also use methods using second generation platelet concentrates. Now when you want to start the practice with platelet concentrates, you wonder like which bulb to use, and these are the various bulbs which can be test tubes which can be used to collect the blood. Sodium citrate, acid citrate dextrose, There are various commercial kits that are available in the market, and if you want to prepare a clot or a platelet-rich fibrin, then you have to use a test tube without any anticoagulant added to it. Now something about commercial kits, there are two types of systems available. There are systems which are called as lower systems, where the platelet concentration goes above 2.5 to 3 times above the baseline, and you have systems where the platelet concentration can be 5 to 9 times the baseline. So there is a huge variation in the concentration of platelets, the leukocytes and the growth factors, and they are costly. So these are the two negative aspects of the commercial kits. However, it is a single step process and it provides us with the ready to use PRP. This is the advantage, and there is less handling when we are using the commercial kits. Now let us see how we do these procedures. So when we are using first generation platelet concentrates, the end product that we get at the end of it is called as PRP, or platelet rich plasma. And it can be done by two methods, the PRP method and a Buffy coat method. So in our practice, we use PRP method. It differs from the Buffy coat method in the spinning speed. So when you are using a PRP method, the first spin is a soft spin and a second spin is a hard spin, at the end of which you get a platelet concentration. So a centrifuge that we use is a temperature controlled centrifuge because the platelets are heat labile. The first spin is a soft spin, maybe 1200 to 1400 depending upon the system that you are using, and the second spin is usually a hard spin. The final product that we get when we collect a blood, whole blood of 20 cc, you may get a final product of 3 to 5 cc where the platelets are concentrated, what we call as a platelet rich plasma. And when you look at the counts, usually we find that there is 3 to 4 times rise in the baseline platelet count. So if your baseline count is 2 lakhs, it rises around 10 to 12 lakhs after this method. So this is how you can use it. You can inject it, or you can sprinkle it, or you can soak a gauze with the PRP and put a dressing. Now when you go with the second generation platelet concentrates, there are 3 ways by which you can do it. One is IPRF, what is called as injectable PRF. Then second method is a PRF by Chukran's method, and this is the method which is most commonly practiced by all the dermatologists. And the third thing, again we do often use it, which is called as a PRF membrane formation. So when we are using these second generation platelet concentrates, here we are using the test tubes without any anticoagulants, because here what we want is a clot and not a liquid form of platelet. So let us see how we go about this Chukran's method. Usually we take about 10 cc of the venous blood, and it is centrifuged at 3000 RPM in a bulb without any anticoagulant added. So once you spin it, you have 3 layers. The lowermost is RBC. In between is your platelet rich fibrin that you can see here, and the topmost layer is a platelet poor serum. So after spinning it at 3400 RPM in a bulb without anticoagulant, you have these 3 layers separated. So you can see this, this is the actual 3 layers, and you can see that in the middle photograph you can see the clot that is obtained, and this is the clot that we usually use for dressing the wounds. So before you put this, you have to scrape the floor and you have to achieve a clean floor, and then this clot is removed. It is placed on a gauze piece and you can directly put it over the wound. You then dress it, and the dressing is usually changed after 7 days. So we keep it on for 7 days. Second way of using second generation platelet concentrates is preparation of the membrane, and I will be sharing 2 different ways which we do. One is by simple compression between the two gauze pieces. And the another method that we use is with a jello net and a collagen sheet, a dry collagen sheet and a jello net that we use. Two more methods are there, but they are time consuming, and when you are in a busy OPD, you don't have so much of time, as well as they do not have any added advantage over these two methods. So these two I will not be going into the details. One is by using calcium chloride bottle, and second is by using specialized chambers. So this is what is a calcium chloride bottle, where the membrane is obtained after about 25 to 30 minutes. So we don't normally practice this in our practice, and this is how a membrane is obtained at the end of this method. The second one is using these specialized chambers. So you can place a clot, and then there is something which compresses this clot. The platelet poor plasma is drained out and you get a membrane. Again, you don't need such a sophisticated chamber to compress it. So you can just compress it between the two gauze pieces to obtain the membrane, and you can see once you squeeze it, all the platelet poor plasma is soaked into the gauze piece, and what you get is a very thin transparent platelet the membrane, which can be directly placed over the raw area. So this is a membrane by squeezing it between the two pieces of gauze. And another way that by which you can do it is by using a dry collagen sheet and jello net. So this is a dry collagen sheet that you can see here. This is a gauze piece on which you will, jello net on which you will put this collagen membrane. After spinning, whatever the platelet poor plasma and is there, you pour it over this dry collagen sheet, let it stand for some time, and then it forms a membrane. And you can use this membrane. You can see that now it is not dripping, and you can put this dry collagen sheet over the wound to dress the wound and leave it on for 7 days. So what is the advantage of this membrane over the PRF or maybe the PRP that you use? Here you don't have to compress anything, so it's a rapid method. Then you can cover a larger ulcer by using this dry collagen sheet. It improves the platelet and the growth factor yield because you can achieve a firm contact because everything is under this sheet of collagen, and it provides a more suitable biological dressing for wound healing, and of course it is very cost effective. So last two methods which I discussed, this is what we practice in our dermatology OPD, and this is the head-to-head comparison of all the different methods as far as the number of spins, the anticoagulant use, the type of bulb that we use, and the centrifugation speed and the duration of centrifugation. So this is how it is performed. So if you are doing it by PRP method, it is a two-step procedure. Again, a Buffy coat method is a two-step procedure. PRF membrane and IPRF, these are single-step procedures. Now, anticoagulant use, when you want a clot, you use test tubes without anticoagulant. So last three, you don't require any anticoagulant. And here in first two methods, either you use a sodium citrate or a acid citrate dextrose bulb to collect the blood in the first step. Now, centrifugation speed and the duration. In PRP method, it is first is a soft spin. It can vary from 11 to sometimes 1400, and it is 12 minutes. Whereas second spin is a hard spin. The spinning speed is double and the duration is almost half. So it is 2405 minutes. Buffy coat, it is opposite. First is hard and second is soft. PRF, it is around 2400 to 3000 RPM for 5 minutes. And for membrane, it is 22. If you are using 6 ml of blood, it is 2200 and 3 minutes. If you are using 8 ml of blood, it is 2600 and 3 minutes. And if you are using 10 ml of blood, it is 3000 RPM and 3 minutes. And if you are using injectable PRF, it is 700 RPM and 3 minutes. So this is an important slide. This will help you to obtain a desired concentration of platelets at the end of each method. So how this PRP differs, or how, what is the comparison of PRP, PRF and IPRF? So does this PRF and IPRF have any advantage over PRP? Let us see in the next slide. So PRF, usually the fibrin is there in PRF because it's a clot, and this fibrin acts as a natural biopolymer. Now it also acts like a cell scaffold and adhesive, so you can achieve a firm contact with the wound. Slow polymerization is there, so the release of growth factors and the cytokines is steady. So over a period of time, the platelet derived growth factors and cytokines would be released, and they help in the wound healing. And it also supports the cytokine enmeshment and cellular migration. There is no biochemical handling. It is simple, it is cost effective, and thrombin and anticoagulant are not required. It also a supportive effect on the immune system, and it also helps in hemostasis. Only drawback is that the network of fibrin that we achieve at the end of this is very fine, it is flexible, and it is rapidly degradable. So this is a comparison of PRF versus PRP. And now comparing IPRF, that is injectable PRF, and PRP. IPRF is nothing else but PRF in an injectable form, and when we say PRF, we are not using any anticoagulant for the spinning. So here it releases higher concentration of growth factors for a longer duration of time. So even after 10 days, we find that the growth factors are released in the wound. So that is one advantage of IPRF. So enhanced regenerative potential for IPRF versus PRP. However, when we are using IPRF, it remains in this liquid injectable form only for 15 minutes, and hence we should be able to complete our procedure within this short period of time, that is 15 minutes. Now second part of my lecture is grafting techniques, and I am going to cover it only in 2 slides. As a dermatologist, we use very simple grafts, either a follicular unit graft or a punch graft. Now what is meant by a follicular unit graft? Follicular unit graft is what is called as FUE. So we have small punches. The occipital scalp is chosen as a donor site, and a very small punch, about 0.8 to 1 millimeter size, is used. You can harvest these grafts from the donor area like this, and these harvested grafts are kept in a petri dish with normal saline in it. So the principle behind using this follicular unit grafts is that you are using the entire hair follicular structure, and the hair follicle, in the bulge area of the hair follicle, there are stem cells and the mesenchymal stem cells. So these stem cells are transferred to the ulcer bed, and they help in healing of the wound. So there is migration of the epithelial cells from the hair follicle to the ulcerated area, and this helps in faster healing of the wound. So this is one method that can be followed, and the second one is another simple method, which is punch grafting, and here the sizes of the punch that we use are little bigger than what we use for FUE, and about 4 to 5 millimeter size punch can be used. They are placed at a distance of say about 4 millimeters, so you keep a gap of 4 millimeters between the 2 punches, and the healing with punch grafts harvested from the hairy scalp gives better results than a non-hairy area. So you can use it either from the occipital scalp, or sometimes we use the punch grafts from the waistline of the patient. So this was a patient of hidradenitis suppurativa where the proper skin grafting was done, but there was failure of the uptake of the graft. So what we did is, from her waistline, we have harvested these 5 millimeter size punches, and they are transferred to this recipient area. Dressing is given, and it is kept on for about a week or so, and we observe for reepithelialization. So this is something like an island grafting by using punch grafts. So this was a case of pyoderma gangrenosum where we used platelet-rich fibrin as a dressing, and we got very good results in less than a month's time. So here the results are very rapid. Another one with non-healing ulcer because of the insufficiency, venous insufficiency, again good results. Another patient where we did PRF. So PRF definitely gives results. It helps in faster healing of the wound, and you can see that this leprosy ulcer also healed quite nicely in less than 6 weeks time after using this PRF dressing. Now coming to the last part of my talk is a honey ghee dressing, and this was a very good paper. It is a landmark paper by Dr. Udvadia, who has used this honey ghee dressing for infected wounds in a surgical ward, and this is how we do it. We use this Dabur honey and we use this Govardhan ghee in a sterile container. So we use a sterile urine culture bottles, and it is mixed in a proportion of 2:1, 2 parts of honey and 1 part of ghee. We mix it properly, and then we put sterile gauze which are impregnated with this homogeneous mixture, and these sterile gauze pieces are then placed in the wound bed. You can cover it up with the elastocrepe bandage, and again we change the dressing once we see the soaking. So if it is not soaked in 3 or 4 days, you can leave it on for 1 week or so before you change the dressing. So this can be taught to your patients and they can do it at home. Why honey? Because it has 3 properties. It has acidic pH and high osmolarity, and therefore it has antibacterial effect. Because of the high osmolarity, it draws fluid from the tissues and it helps in reduction of edema and pain. And also there is improved tissue perfusion, improved oxygenation, and free flow of leukocytes and fibroblasts. There is angiogenesis and reepithelialization with healthy granulation tissue formation. Then its enzymatic effects, the protease enzyme that is present in the honey helps in desloughing and debridement of the wound, and it also limits the pathogens. And the immunological effects are it stimulates cytokine production and it stimulates proliferation of T and B lymphocytes. So this is how this honey acts. And why we add ghee? Because it blends homogeneously with honey and it augments its local action. The honey otherwise becomes watery at body temperature, and it is very difficult to maintain the contact with the wound. So when you add ghee to it, the contact is better. So it increases the viscosity of honey and it stays in place for a longer period of time. So it also acts like an emollient. So this is the way that we do. This is the way that we follow this honey ghee dressing. And what we observed after this is that it has desloughing effect, it has antimicrobial effects. The scar that forms at the end of it is a pliant scar. It is not a hypertrophic or a very thick scar. It also hastens wound contracture. There is reduction in the pain, and of course it is very, very cost effective. And when you are using various commercially available local ingredients, there is a chance of dermatitis medicamentosa which is not there with this kind of a natural dressing. So this was a patient of actinomycotic mycetoma where we did debridement, the surgeon did it, and there was this kind of a large defect which they were planning to do a grafting, but we put this patient on a honey ghee dressing, and you can see that there is excellent healing of the wound, and you can see that the scar is very pliant and supple. So this is how actually it works, and it really gives good results. Another patient who had tried almost everything, and just in 1 month's time the wound healed completely. Another one, and this is a stoma which showed good healing at the after the honey ghee dressing. So the take home message from my talk is that PRF and honey ghee dressing, they are simple, cost effective treatment options for acute as well as chronic ulcers. In the resource poor situations, honey ghee dressing is an excellent option and can be done at home after you teach it to your patient. And both the methods are effectively reduce edema, pain, and reduce the ulcer size in 2 to 4 weeks. So thank you very much for your patient listening. I had videos, but I think we don't have time for videos.
We'll address questions at the end of the session. Thank you, ma'am, for an excellent talk and for walking us through effectively through some very simple yet effective techniques of wound management. I now hand over the mic to Dr. Nikhil, and he'll introduce the next speaker to us.
We are short of time, madam.
Question answers at the end of the session if there are any from the audience. Video, ma'am, we are short of time, so...
To share with us the plastic surgeon's perspective, may I request Dr. Shaunak Sule. He is a leading plastic surgeon in Pune and a consultant at Dinanath Mangeshkar Hospital. He is an alumni of BJ Medical College. He has done his MS General Surgery from BJ and MCH Plastic Surgery from GMC Baroda. He has published extensively in various scientific journals. I hand over the mic to Shaunak.
Thank you all. Thank you, Nikhil. गुड इव्हनिंग ऑल. 5:15 वाजता प्लॅस्टिक सर्जनच्या हातात केस मिळाले, त्यामुळे मला शिंदे मॅडम दिसत आहेत, नाईक मॅडम आहेत. काळजी करू नका, वेळेत फ्लॅप संपवतो.
To add to what you have said, Shaunak, plastic surgeon's reputation is at stake. Huh? Please be on time.
Yes.
Yeah, the dermatologist has already set an example. So now it's time for the plastic surgeon to follow suit. Over to you, Dr. Shaunak.
Hello. Yeah, thank you. ते काय येत नाहीये? Honored to be at my home ground and delivering this talk after so many years. Thank you to the organizing committee, Dr. Nikhil. And it's always wonderful to have your friend, philosopher and guide as the chairperson. The only thing I am not worried that he's not going to ask me any questions, because he was my third year at plastic surgery. So I'll just take you through a small tour of plastic surgery and what it is. And plastic, as we all know, it means the art of modeling or remodeling of flesh. It originated in India, and Sushruta was the father of plastic surgery. Common misunderstandings that we all know: plastic surgeons use plastic in surgery. Plastic surgery gives no scar. Yes, that is the commonest myth, I would say. And most of the relatives who come to us at consultations want scarless surgery, but which is actually not possible. It has a lot of complications and morbidity, which is not very true, but not false either. And it is meant only for rich people is another myth. So plastic surgery, as we all know, through these times, is through Bollywood that we have been introduced to plastic surgery. Even I was introduced to plastic. Zinata Mann in Satyam Shivam Sundaram, she had that scarred face. Then recent times, Deepika portrayed that girl. And Face Off, herein face transplant has been shown, but which is a reality these days. So why plastic surgeons and wounds? Because we heal wounds faster. It's the final treatment expected to be. And the finesse, which is the major part of a plastic surgeon's career, that it has to be fine. No matter what you do, the scar has to be fine. That is what is expected. The scope of plastic surgery is vast. We can see birth anomalies, facial trauma, upper limb extremity, upper limb and lower limb trauma, reconstructions, vascular injuries, post-cancer reconstructions, and a newer era is cosmetic surgery. So this is the spectrum, and the central slide is the reconstructive ladder of plastic surgery, wherein we start from the basic. The lowermost rung is the basic procedures like skin graftings, simple suturings, and the topmost rung is the microvascular procedures, which are the recent advances that have developed over the past. Now the major mantra of plastic surgery is, for any type of wounds related to any department or any surgeries, is immediate debridement and cleansing, prompt coverage, repair or fixation, immobilization, physiotherapy and rehab. So this is the main goal that we plan to achieve in our plastic surgical practice, or the main mantra that we follow. These are some of the representative such slides that I could gather, that many a times you will come across these patients in your clinical practice. All sorts of birth anomalies, congenital anomalies are now taken care of by plastic surgical procedures like cleft lip palate, hemifacial atrophy, or any sort of facial deformities. They are very well treated with advent of newer microsurgical techniques which are called free flaps or free microvascular transfer. Facial traumas are now handled very nicely because of the immediate cleaning, debridement, surgeries, and repair of the wounds. Such complex facial traumas now can be very nicely handled because of this mantra of plastic surgery, wherein the patient is taken immediately to the theater, and you can notice the patient has really minimal scars. Facial fractures are, the treatment of facial fractures is changing over times. There are good rigid fixation methods available. A lot of implant materials are available these days, and the implant materials also have refined over times. So from using stainless steel to titanium plates, the concept of fracture fixation for facial fractures have changed. Coming to upper limb and lower limb, what we as plastic surgeons achieve is giving function to the hand or limb, which is of prime importance as regards vocational rehabilitation of the patient. So such patients in the past would have been managed by amputations, but now since we can take these patients to the OT immediately and reconstruct them with microvascular techniques, these patients do very well. And you can see even with 2 fingers, he is able to at least do some sort of work. Similarly, crushed hands can be treated with all these refined techniques. Hand replantations, limb replantations, penile replantations are the most recent advances that have come up over the last few years, owing to the new microsurgical techniques, the microscopes that have been invented, and the refined suture materials. You can see 11-0, 12-0 suture materials are available, which can make this possible. These are just some hand injuries which have been reconstructed. You can see lower limb injuries. Diabetic ulcer, as madam has already described, is a main concern in India and all over the world. So diabetic ulcer treatment takes a major seat in plastic surgery management, wherein we immediately debride the wound and cover the wound to prevent any further amputations of the limbs. Foot crush injuries are similarly managed with microsurgical techniques. So are vascular injuries. Post-oncosurgery reconstruction is another part of plastic surgery wherein the scope of plastic surgery has totally changed. We are able to reconstruct the resected jaw with the principle behind this is similar replacement of tissue. So bone is replaced with bone, and that is what is seen here, wherein a free fibular flap or a microvascular flap from the lower limb is taken and the mandible is reconstructed, and you can see the result. So in the previous era, this was not possible, and this is a most recent advance, I can say. Lymphedema surgeries are another surgeries coming up over the last 5 to 7 years, wherein at Sassoon, in my residency days, I would see these limbs coming over to the casualty and I would refer them from the minor OT without my seniors being aware of it. But now, yes, these surgeries are being done in India also, and you can see the wonderful results of these vascularized lymph node tissue transfers, which really are helpful for these patients. Burns, another major part of plastic surgery, has been revolutionized because of immediate cleaning, debridement, and collagen application. You can see this patient of firecracker burns, which are presented to us in Diwali, and see how his results are after immediate debridement and collagen application. So collagen is an artificial skin substitute which can be used to give a better cosmetic result. Similar face burns. Hand burns, yes, hand burns also need good vocational rehabilitation by giving him a good surgical release, grafting, and then splinting and physiotherapy. So function is the major part which is stressed upon in plastic surgery. Some recent advances, we are all aware of vacuum therapy, which is called vacuum assisted closure. Vacuum is essentially a foam, a polyurethane foam which is placed on the wound. It is connected to a machine, and the machine gives a continuous suction pressure of around 100 millimeters of mercury, and the wound heals. It basically, what it does is it provides a closed, moist environment to the wound. It removes exudate, it reduces edema, and it promotes good perfusion of tissues, and plus it promotes granulation of tissues. So this is a recent technique which helps in all chronic wounds for all sorts of wounds. Advances in VAC therapy are nowadays, Veraflow VAC therapy is advised, wherein this foam irrigates topical antibiotic solutions also, so that we get faster healing of the wound. These are some case studies of VAC, wherein you can see after application of VAC, the wound granulates at a faster rate, and you can cover the wound with skin grafts or flaps, and just the patient can get back to work. So the downtime is reduced. Another example. Another thing, oxygen. After post-COVID, all of us know what is the importance of oxygen. So is the importance of oxygen in wounds. So hyperbaric oxygen was previously given, which is a systemic therapy. Now comes the multimodality therapy of topical oxygen therapy, wherein a chamber is placed, I mean the limb is placed in a chamber, and it is exposed to a oxygen environment, so that the wound granulates at a faster rate. So these are adjuncts to the previous methods that I have shown, that is skin grafting and flaps, but wherein the downtime of the patient's dressings and overall duration is reduced. HBOT is much cumbersome. The patient has to go in the chamber. There are a lot of contraindications. And topical oxygen therapy is very simpler. It's available everywhere, and it is much patient friendly. So these are the chambers. These are multi-patch topical therapies. These are the photos of a topical wound oxygen therapy, wherein the wound granulated at a faster rate, and we could graft it, and within 3 to 4 weeks the patient could walk. Dermacell is another recent technique that has come over. It is a cellularized human dermal matrix. Basically, a wound is, what a wound is there is no dermis in a wound. So we need to give a good extracellular matrix cover, and replacing that dysfunctional ECM is the major role of this Dermacell. So Dermacell is basically human cellular matrix or a dermal matrix which is placed on the wound, and the wound granulates on its own. So the advantage being it does not require a skin grafting after that. Of course, it is it is in its primitive role at present, and the cost is too high, so it has not been in practice much. It is very useful in all sorts of chronic wounds like diabetic foot ulcers or pressure sores, but at present the size of the wound is a limiting factor because of the cost of this Dermacell. Pressure ulcers, as I said. So futuristic goals in plastic surgery are fat grafting and platelet-rich plasma, which Madam has already described. Fat grafting is another venue wherein lot of openings are still there. We use fat grafts for face rejuvenation, breast augmentation, and many surgeries. Cultured epidermal autografts are on the horizon, but they are also limited in clinical practice because of the cost issues. Synthetic skin substitutes are BioBrain, Integran, Apligaf, but they are limited because they are synthetic, so they are not taken up well, and they need a skin graft later on. Growth factor gels are available in the market. They also have an adjunct role in clinical management of wounds. And the further recent trend is hand transplantation and face transplantation, wherein these are also coming up on the horizon, which will definitely revolutionize the wound management. Thank you all.
Thank you, Shaunak, for a wonderful presentation. Both the papers are open for a single question, if any, for each presentation.
Hello. Ma'am, is there any need to sterilize honey and ghee before we apply it over a wound?
Honey and ghee, no. These two we had actually sent the samples for culture, and there was no growth. So it seems to be a sterile this thing. So you don't need to sterilize it. The container has to be sterile.
Which, ma'am,
container in which you are going to mix it, and the
plastic.
spoon that you are going to use it to mix, both should be sterile.
Okay, ma'am.
So
Thank you.
we actually ask the patient to boil water and one small vati and chamcha, they have to put it like how we do it for feeding the kids, and they have to boil it, it sterilizes it, they mix it, and they have to do it only once in a week. Like they can't keep on using the same thing. They have to prepare it, use it, and make it again when they want to use it, if they are doing it at home.
Okay, ma'am. Thank you. And does the wound have to be uninfected? If there are wounds which are very oozy, infected, discharging?
Actually, this, I already told you that it has action, enzymatic action is there, so, and it also has antibacterial properties. So even if the wound is infected and even if there is edema around it, you can use it, but it is always advisable to clean the wound, make the surface raw, and then use any dressing.
Light debridement can be
so
done, of course.
wound,
Madam, would you advise it to do at home? It is better to be done under supervision.
no, sometimes
Because
patients stay far
patients
away.
do not know how to use a sterile cotton and gauze.
No,
So
we
it is always
actually,
better to use it under supervision by a health
So
professional.
that needs counseling. We do that properly, and if we are convinced that this particular patient is going to follow all the precautions, then only we advise it at home. Otherwise, we call them to the
Yes.
clinic.
Dhanashri, on lighter note, in Pune, can we use chitale ghee? And
You can.
because you specifically said in
You
Pune
can.
it will not be allowed.
Chitale,
We should.
actually, now they also have come out with a container which is airtight, because previously they used to take
give
it out
in,
from the
yes.
dabba and give it, but now they are
On
also the new
professional,
generation.
this thing, has anybody taken patent for this?
Patent. That I don't know.
Not to the best of our knowledge, no, we don't.
Patent.
Now, madam, one thing you mentioned upon the different techniques. How are they cosmetically effective as far as the scars are concerned?
I didn't get you.
Scars, the scars resulting from these techniques. So how do you compare the scars resulting from the healing of these wounds?
And all previous preparations.
See, actually, when you use these as adjuvant therapies, the healing of the wound is
PRPs.
faster. So, like if you leave it untreated like that, and if it is going to take 2 months for the healing, if you use one of these techniques, we really see the results in 2 to 3 weeks' time. So the amount of inflammation and the duration, it's all about inflammation and infection. So it is like if you control it earlier on, then of course the resultant scar is going to be better. So secondary intention healing will take place, but it is going to take really long. And I had shown you 1 or 2 patient photographs where you could see that the scar was really soft and pliable. It was not a hypertrophic scar after using these techniques.
So, can
Any
I
question?
ask a question? One for Dr. Sure, please. Yeah.
Yes, madam.
Have you tried using placenta and stem cells which are collected from the same like bone marrow?
Yeah.
Have they been placed on the ulcers and seen a healing?
Yeah, it was being used. Placenta was used, but there are sterility issues also again. They can be made sterile, but we don't prefer using placenta nowadays. We go for collagen, which is very widely available, and it has really lesser rates of infection. Plus the acceptance is also very good, what we have seen.
Madam, we have Placentrix gel available.
No, that
Gel
gel is
is
available.
Extract.
The extracts are also available. But,
Yes.
the
But that
fresh
is also commercially available, which is totally non-allergenic, which is tested for hepatitis B, and it is used by us with
but
good
that
results.
is, I think,
Amnion is also available.
amniotic membranes are also used.
They were being used, but nowadays with the advent of collagen sheets, the usage has gone down because collagen is very widely available.
Widely available.
Yeah.
What about like how we use platelet-rich plasma? Have the stem cells been used?
Platelet-rich plasma is very widely used in hair transplant patients, or say if there is hair thinning. Plus PRP has wider application in facial rejuvenation, what we have seen. So all sorts of facial wrinkles. Plus if you want to give a fuller facial appearance, we give fat with a PRP mixture. Even we do a lot of fat transfers for breast augmentation or buttock augmentation, wherein fat is mixed with these stem cells. So the fat resorption rate is reduced. So at 3 years down the line, we see more of fat being there. That is what has been observed. Because these studies have come over from Japan and Korea, where the patients are very thin. They don't get much of fat. And so they use all these PRPs and stem cells so that the fat is less resorbed. Yeah.
Okay, thank you.
Thank you.
One question to doctor. Basically, we are dealing with the wound management, and in working in Sassoon near the hospital, the healing wounds do not pose any problems. Problems come when the wound goes in chronicity, especially if the diabetes, whatever the ulcers present on the sole of the foot or the pressure source. So what is your experience about these deep-seated ulcers, especially over the pressure-bearing areas?
Yeah,
and diabetes, that is a difficult problem. Basically, we have to avoid this. But if it happens, do you have any protocol of management, when to use VAC or when to use other your newer methods?
Yeah, so chronicity is always a problem because most of the times we come across patients after it is being treated by a lot of practicing
These patients wander here and there.
Yeah, so once we see the patient, what I said, that immediate cleaning or debridement is the primary surgery that all plastic surgeons take up. Many a times what we keep on doing is we just dress the wound. It forms a biolayer, and the wound will not heal unless you scoop it or unless you freshen the margin, which has to be done. So you need to immediately debride the wound, and then you can take a call depending on how the patient condition is, that if you can go in for a vacuum therapy, it's always good. If the patient cannot come to the hospital setup, you can use a topical oxygen therapy, or then depending on the wound size, you can decide to giving a dressing with all these growth factor gels which are available, Pleural or Regen or Silvergen, whatever are available nowadays. Or else if it's related to function, or if a vital organ is, if the bone is exposed or anything of that sort, you need to go in for a flap straight away.
Yeah. Yes, thank you.
Hello, Dr. Shonak.
Yeah.
I'm interested in that oxygen therapy for wound healing. So what is that?
Topical.
Topical oxygen therapy.
Yeah.
What is the pressure? Can we use here?
Yes,
or is it available in our institute?
It can be made available here. They can give the set, they can keep the instrumentation over here. It's just a chamber. The patient has to, the chamber is applied to the foot or the hand, and the pressure is around 10 liters of oxygen is applied for around, say, 90 minutes. And we need to compare the size of the wound on serial dressings. So within, say, 5 to 7 dressings, the wound reduces in size, and then you can go and graft the wound. So what we have seen, it's just come up on the horizon like. So you can get in touch. I mean, I can give them your contacts, and they can house the instrumentation over here. So it can be started as a wound care clinic here.
Thank you.
Okay, thank you.
Thank you. If there are no further questions from the audience, I think we can conclude this session. On behalf of the organizing team of the 48th conference of the Research Society and our team of chairpersons, I'd like to thank the speakers, Dr. Dhanashree Bhide ma'am and Dr. Shaunak Sure, for their excellent presentations. Over to you.
I now request the chairpersons to kindly felicitate our speakers for today, Dr. Dhanashree Bhide madam and Dr. Shaunak Sure sir. I now request Dr. Kalpana Kulkarni madam to kindly felicitate Dr. Nikhil Panse sir. I request Dr. Nupur Chowdhury Madam to felicitate Dr. Harish Umrajkar sir. I request Dr. Pragya Mishra Madam to kindly felicitate Dr. Vasudha Belgaonkar Madam. With this, we conclude today's scientific session. I want to remind you all, kindly submit your feedback forms for your MMC credit points. This session will now be followed by a general body meeting for the